Welcome one and all to our webinar for this evening based on World TB Day 2026 themed Yes, We Can End TB. On behalf of the Nurseslab's team, we would like to thank you all for registering and supporting our online platform by attending our webinars. Do stay tuned and continue to follow us on all our online platforms like WhatsApp, Facebook, Instagram, and our YouTube channel as we post daily updates on nursing and nursing related information. We also have various platforms for preparation of competitive examinations like CBT, NCLEX, OET, DHA, and MOH exams. So visit our website www.nurseslabs.in. I would now like to take the privilege of welcoming all our 6 speakers for this evening: Mr. Amalraj Ravi, Mrs. Relu Sanjo, Dr. Vasantha Gurusamy, Mr. Tamil Pulavendran, Mrs. Mercy J, and Mrs. Rekha Bijuvarghese. Thank you all, dear speakers, for gracing this event and taking the time to share your valuable thoughts and information with us today. I would now like to welcome our first speaker for this evening, Mr. Amalraj Ravi, Manager, Hospital Administration and Quality Management, Kanchi Kamakoti Child's Trust Hospital, Chennai. With over 15 years of extensive experience in the field, Sir has a vast experience in various audits as well as research projects that has brought out the management qualities and his excellent nursing skills. We welcome you, Sir. The topic that Sir will be speaking on is the nurse's role in ending TB from bedside to community. Over to you, Sir.
Thank you, Danya. Good evening, everyone. And so to start with, the topic is about the nurse's role in ending TB from bedside to community. So tuberculosis. So as you all know, it's a global health challenge. It's not only in India is struggling about, or lower middle class countries are struggling about. It's about the entire nation is entire countries are worldwide is struggling about. So it's a major public health issue, and nurses are actually playing a crucial role in TB control and elimination. So if you look at this picture, so nurses actually playing a vital role as they are playing between the bridge from the hospital to the community side. So they are actually playing the crucial role to understand the background actually. So I just put on some statistics so that we'll understand where we are, what is the importance of this particular TB, because TB is a common one we are hearing for a long period of time from our childhood, but still why people are talking about TB and taking initiatives of TB. So if you look at here, so this is in statistics of the year 2024, WHO's report, based on which in the year 2024, Southeast Asia has been, the percentage of Southeast Asia's tuberculosis cases about 34% out of 87% of overall. And Southeast Asia alone contributing 34%. And if you look at West Pacific region, they are contributing 27% out of 87% of the global cases. And if you look at the African region, it is about, they are contributing about 25%. So this gives an idea about where we are and why it has been a global challenge. So TB burden countries, so out of which there are 30 countries majorly been highly affected of cases out of this 87%. So among that, if you see that the top 5 countries are contributing about 55% in the global rate. So if you look at the top 5 countries, India has been contributing 25% out of 87%. And Indonesia is contributing 10%, and Philippines is contributing 6.8, China is 6.5, and Pakistan is 6.3 respectively. And follow on Nigeria and Congo and Bangladesh is coming. So when it comes of TB burden, India has been taking a lot of initiatives. However, we are being 2/3 of the population we are been contributing, our cases are been still existing. So what sort of activities or implementation is India actually be taking about to control or eliminating TB? So to understand the history and what is the contribution that India has been given to control and eradicate this program, TB control activities has been initiated 50 years ago. So imagine we have started initiating the National Tuberculosis Program in 1962. Still in the year of 2026, we are struggling to eliminate or control to support the global program. So in 1993, WHO has declared that this is a global emergency. So they have recommended everyone to directly observed treatment short course, that is usually called as DOTS, the DOTS therapy. So government of India has synthesized this particular program and revitalized this national tuberculosis program into revised national tuberculosis control program. So that we usually call as RNTCP in the year of 1993. The same year they have revised the program and they have been modified the program based on our Indian community. So the DOT was officially launched as revised national tuberculosis control program strategy in 1997. So if you look at from 1962 to 1977, and we have been almost 30 years, we have been struggling to do map up. So in 2005, the entire country was covered under this program, which means the DOTS therapy. So Indian government has been confirmed that every patients fall in this particular category has been ensured they have to be followed through directly observed treatment, the short course therapy, which is about 2 months of intensive care and 4 months of continuity phase of program. We'll see it in the upcoming slides. So what is about RNTCB to NTBEP? So it is about revised national tuberculosis control program to national tuberculosis eradication program. So government of India has been taking much efforts to eradicate this program from India. So in 2020, our government of India has been launched a policy stating that this program is going to be a national tuberculosis eradication program rather than still we are been controlling this particular dangerous disease. So they emphasizes this aim to eliminate the disease out of country by 2025, which means that the global trends is about the global target is about 2030, which they have provided a sustainable development goals with the baseline data in 2015. They have compared with the 2015 data globally, and they have set a target of 80% reduction in the incidence of TB cases and 90% reduction in the mortality and zero TB cases with the by 2030. So this is what the global aim, and India has been fixed our own self target of 2025. We need to be eradicating the program. So out of all this effort, they have put in a strategy of 4 pillars, which we all been called as DTPED, which is they have initiated a national strategic plan with the workout of 2017 to 25. They have extensively provided a lot of benefits, a lot of monitoring system, a lot of human manpower has been assigned for it to detect the early cases and to detect for the cases at the for the drug sensitivity and drug resistance. So there are patients those been affected for TB cases. They are majorly been withdrawn about the TB medicines. They are failure to withdraw the medications for 6 months of program for the pulmonary TB and about extra pulmonary about the 1 year, or some of them are taking treatment for 24 months, which is 2 years. So some of the cases, active TB cases, has been detected for the drug sensitivity and the resistance, and they will also try to monitor and catch out the active cases and through the home visits and the early identification of the symptoms. And high risk cases has been identified, high risk groups, which has been HIV patients or any comorbidity patients which are been likely to get easily affected. So these people, this is their major aim in detection. Detect the case. Their strategic plan in detect is there. These are the things they usually detect. So when it comes for treatment, they are initiating the treatment at the earliest moment. So they have to start treating, and they need to sustain using the ATT, anti-tuberculosis medications. So that is their initial phase, and adherence to the treatment. So continuous follow-up and continuous monitoring through the home visits and through the social workers, through the ASHA program. So this is the initiative they have been followed to early recognition and treat the illness at the fast. So that is what their major goal. So prevention. So prevention is better than cure. Everybody will be usually talking about. So what they prevent. So before it comes to us, so the infection control protocol should be standardized. So isolating the patients, so putting them on proper vaccinations and strategic prevention measures through educations and preventing the social stigma. So all these things measures to collectively put the patients to prevent from the illness. So this is what the objective of prevention. And build. So build, they are talking about something about the policy, streamlining the policies, strengthening the policies to control and to engage the community engagement programs, providing awareness and making the healthcare system to be tightened. So these are the strategic pillars. We usually call as 4 strategic pillars of National Tuberculosis Eradication Program. They have implemented in 2017 to 2025. So out of all this effort, what has happened? So during this program, government has been measure the data. So the data this has been collected from Ministry of Health and Family Welfare. So the program is called the TB eradication program we are talking about, but the program is named as TB Mugud Bharat, which is the government of India has nominated us and accelerating the process of elimination of these TBs from the country. So India's fight against this tuberculosis from 2015 to 2024. So the TB incident has been down from 21%. So which is in 2015, 237 cases have been reported for 1,000 every 1 lakh population. So in 2015, it was 237 for 1 lakh population. It has been down to 187 for 1 lakh population, which is nearly double the global rate of decline. And the treatment coverage, so they have covered the treatment up to 92% through all the social engagement, NGO program and non-NGOs. So private sector involvement and information of the cases through each government and private sectors. So they have reached the treatment up to 92% all over the country. So that is the coverage they are talking about. And 90% of treatment success. So they are covered 92% of treatment, out of which 90% of the treatment becomes success. So the mortality rate has been drastically down. So which has been a very success for this TB Mugud Bharat Abhiyan program. So they have increased the budget. Not only this, they have also increased. They understood that because it's need an intensive care to eradicate the program, which is a global challenge. They have provided and increased the budget allocation for TB eradication. The budget has been 10 times higher than the program for the last 9 years, which is between 1915 to 2024. So, and finally, 4,406 crores, I'm repeating, 4,406 crores amount, which has been given to this particular project called under the project of Nikshay Pojan Yojana, which is about, there are people socially low economic background only been affected for this TB program because of their economic background and their malnourished and undernourished. They could not able to get the adequate nutrition. So for which, that is the major reason they could not able to get a better nutrition or a high calorie food. So government of India has decided to provide. Earlier they have provided 500 rupees per month for 6 months. Right now they have increased at 1,000 rupees per month, which is for 6 months. They are provide a high calorie and nutrition program. So the fund has been increased 10 times. So these are the statistics. So out of all this effort, what is the statistics right now? So yes, we can end TB is the theme we are talking about today. But still, through this program, through this initiative, we have saved 83 million people since 2000. The data has been captured from 2000. We have saved 83 million people. We can make ourselves a clap. However, this TB has also been killed 1.23 million people has been died so far. So currently 10.7 million people have been treating all over the world for TB program in 2024. We are talking about something 2030 to eradicate it completely. However, till we have been struggling about to reducing the cases of 10.7 million cases are still struggling about. So this is where we have been come to the picture. Before going to talk about nurses' role in clinical and community, I would like to have a quick review of you, because I don't know how far you have been hearing from me, because I'm talking more around 10 minutes continuously. So let me have some quick questions. Okay, it's very, very simple questions. So what is the causative organism for TB? Can you please pin in the chat section so that this communication become interactive? Yeah, very good. So I'm seeing some of them are very good. Mycobacterium tuberculosis, very good, wonderful. So what are the types of TBs? Can somebody message in the chat? What is the common TB? Yeah, pulmonary, very good, beautiful, good. I'm seeing people are engaging. Thank you. So we can majorly classification as pulmonary and extrapulmonary. Beautiful. So pulmonary is we are talking about lungs, and extrapulmonary is about other than the lungs where the TB has been and the people are getting affected. So brain, spine, and abdominal, like kidneys. Exactly. Beautiful, beautiful. Okay. So how TB is been transmitting? What is the mode of transmission of TB? Droplet, respiratory. So it's transport airborne. Very good. Beautiful, beautiful. So what are the common signs and symptoms? Beautiful, beautiful. Thank you. Wonderful. I'm seeing a lot of people are messaging. Thank you. So what are the symptoms? Beautiful. Cough, breathing difficulty, weakness, weight loss. So weight loss is an unusual weight loss, right? Beautiful, beautiful. Good, very good. Blood vomiting, fever. Good. Thank you so much. So let us move on. So as we said, so tuberculosis, it's been an airborne infection. It's spreading through cough, sneeze, and through the droplet infections. Beautiful. So what is the key role? Now coming to the point of us, what is our key role in as a bedside nurse? So the first point about ensuring treatment adherence. So ensuring the treatment adherence is the first and foremost thing. So when the nurse has been identified a patient has been risk for TB or been diagnosed as a TB, soon over then we need to put the patients on continuous directly observed therapy, which is about classifying on two programs. So it's in 6 months we are dividing in two different methodology, which is in first 2 months is intensive phase, and next phase is called next 4 months is called a continuous phase, where the patient will be observed for whether they are taking medications correctly, and so that if they are taking medicines correctly, they can be prevent from drug resistance. If they are doing this for 100%, the recovery rate has been tremendous, and it's been 100% been recovered. And during the follow, we need to be check for the missed appointment. Any patients are missed for appointments. Any patient has been affected or ill, because of that they could not able to visit the OPD, or anything else happened for the patients. Any social stigma has happened for this patient. All these things should be monitored and traced for the being closely associated with their household and their family and their friends. So these are the areas. And case management, where we will be putting our role for coordination, case coordination, and identifying that, sending for the earlier sputum report by the month of initial period while they are diagnosing, and after 2 months of confirmation, and after 6 months while they are completing, to ensure till that they have been, they have to be ensured that they have been free from the illness. So this is about the coordination of the care and medication dispensing. Usually in the DOTS therapy, they will not give the entire course of 6 months medicines at a single shot. They will be giving every weekly medications. So we'll be seeing the next slide about how it will be given for adolescent and the pediatric doses. So however, they will be providing medications weekly, and for the NGO sometimes they will be providing for bi-weekly based on their convenience. However, weekly, when they are providing weekly, they can able to understand how many medication they have took properly, and whether they are coming up, they are been adherence to the treatment. Those things have been ensured by assuring the treatment adherence. This is about the primary nurse's role, where we will be putting on, and monitoring and clinical management, where the side effect of drugs should be monitored. So there are 4 major drugs will be used in treating TB, where the isoniazid, rifampicin, and pyranizumab, and finally we will be using ethambutol. These are the 4 major antibiotics will be treating for TB. So there are certain side effects is also been monitored by the nurses. So usually these drugs are being metabolized in the liver. So liver function test should be periodically taken to review the hepatic function. So sputum monitoring, the nurse should monitor the sputum culture. So it should be properly collected with the empty stomach. It is advisable. So after the sputum has been, confirmed, then they will be advised for the furthermore tests, and they will be guided for taking the anti-tuberculosis drug. So comorbidities, the nurses also should monitor for the comorbidities. So a patient affected with only TB have 3-4 times higher risk when a patient is having comorbidities such as HIV, diabetes mellitus, or any other associated illness. So if the patient is on any other comorbid illness, the nurse should be very careful to monitor and do the follow-up. However, airborne precautions is the primary one. So we should isolate the patient, make the patients on negative pressure ventilations, and put them on a proper mask. And to prevent cross infections and contamination, we should isolate the patients properly. So, and the HEPA filter should be worked properly at the room. So these are the essential measures the nurse should monitor. Environmental hygiene, The room should be properly cleaned and maintained. The most important thing is the nurse should ensure their wastes, sputums, and their droplet since it's in droplet infections, it should be properly discarded through yellow bin, which is should be incinerated after discarded. So the patient education and counseling, so treatment prevention and education should be given. Medication education, as I said, the the medication should not be withdrawn in between 6 months. Once it is been started, they are high risk for drug resistance if they in between stopped. So in case if they have missed out any doses, they have to do the treatment from starting. If a patient is started taking medication for the first 3 months and they have lived, soon over the symptoms has been slowed down or not been evidenced when it been called as the latent TB. So sometimes the patients may withdraw the treatment. So if that is the case, they have a high risk to develop resistance in the treatment. So if this is the case, then the nurse should ensure the education should be properly given, how to take, when to take. It is good to take in an empty stomach so that the absorption will be good, and no antacid should be taken before 1 hour of taking. In case the medicine is taking after the food, because due to the GA, it should be taken at least by 1 or 2 hours to prevent it. So it is good always before 1 hour or after 2 hours of meal. So these are the basic educations the nurse can be given to the patients, and also the drug side effect, monitor for the side effect and report to the consultant so that the treatment of medications and the drug dosage can be altered based on it. And finally, about social and nutritional supports. So as I said earlier, so the social barrier, the low socioeconomic groups are highly affected for TB. So since it is in most of the people are thinking this is in mid and low socioeconomic countries. So 87% of the low and middle economic countries are being affected out of 100%. 87% are low and middle economic countries. See, from that overall perspective itself, we can understand this is majorly because of the nutritional status. So the high caloric diet should be encouraged and balanced diet should be given. And so that is the major reason the government has been provided for 1,000 rupees for the patients to the Diksha Yojana funds. So these are the key roles a nurse should be ensured to ensure the patient has been met adequate nutrition and adequate treatment has been achieved. So TB drug management. So the tuberculosis, as I said earlier, the patient has been required the 4 important antibiotics: rifampicin, isoniazid, pyranezumab, and ethambutol. It should be taken for 4 to 6 months, as I said earlier. So dangerous if stop medication without medical advices or in between. So it can prompt the TB bacteria into the body and become resistant, as we have discussed. So this is the major important thing about TB management. And when it comes for a drug, so in the TB, it is being based on their weight, because since one of the signs and symptoms is weight loss. So based on the weight and tolerating the liver, we need to titrate the medication dosages between these advices or recommended guidelines given by the TB research center. So if a patient is between 25 to 35 kg, the one which I have highlighted at the top is been adult dosage and the down is been pediatric dosage. So if you look at this, this table, 25 to 35 kg, when a patient is falling between 25 to 34 kilogram, they have been advised of this HRZE is about isoniazid, rifampicin, pyranezumab, and ethambutol. That is the shortcut they have used for HRZE. When you see here, HREZ will be removed. The pyranezumab has been removed. Will be in continuation phase. There will be 2 phases. One is intensive phase, and the another one is continuation phase, which I already told. The intensive phase is up to 2 months, and continuous phase is till the next 4 months. So this ratio is 75% of isoniazid, 75 mg of isoniazid, and 150 mg of rifampicin, and 400 mg of pyranezumab, and 275 mg of ethambutol. So the patient will be advised for 2 pills. If they fall in this particular weight, they will be given 2 pills per day, which is about 4 strips for calculations. Each strips contain 28 tablets. So they will be provided 4 per strips. And the next month, it will be like 4 months. So 2 per day. So they have calculated 8. So 4 into 2, 8. So 8 into 28 strips. So each week, they will be asked to they will be called the patient to come into the area, or the health worker will be visiting their home to giving the drugs, and they will be following up whether their complaints with the medications. So this will be 35 to 49. They'll be going with 3 to 3 pills per day, and 50 to 64, 4, and 65 to 75, 5 pills, and more than 75 kg, they will be putting on 6 pills, or based on the titrative and the side effect of the patient's experiencing. So when you look onto the pediatric dosages, it will be starting from 4 to 7 kgs, and they'll be putting on C plus E is about, C is talking about the short form of H or Z. So the patient will be put on isoniazid, rifampicin, and pyranezumide. So this is about the pediatric dosage, where E is about ethambutol. So C plus E is about H or Z. If you see here, H or Z plus E, ethambutol, that is a value. So we can directly go with this. They have already formulated what is the mg is supposed to be given from each component. So the isoniazid is 50, rifampicin is 75, and pyranezumide is 150, and ethambutol is 100. Similarly, 8 to 11, they will be falling in this 2 times of C and plus 2 times of E, which is ethambutol will be 2. So here there is no confusion like here, because they have pre-recommendedly given the dosages. So if you look at here and there, so the weight will be coming here and there, 25 to 34 and 25 to 29 for pediatric, it will be clubbing. So where the physician should be much monitor in this particular storage, because adult, the dosage will be different, and the pediatric dosage will be slightly higher, because if you put here, they'll be putting an adult dosage, A plus 3C plus 3E. So this is only confusions we usually occur. So that is the reason they have put on dosages 225 plus 375, 850. So this is a standard recommended ratio, and we need to consult with the pediatrician based on the side effect which we have already discussed. We need to consult with the physician, and we need to titrate the dose, and we need to provide and monitor the effective prognosis. So this is all about. So when you look up here, the new when it is a new cases, new microbiologically confirmed TB cases will be addressed, and new clinically diagnosed TB cases will be addressed, and will be treated, put on the 2+4, which is in DOTS therapy methodology of regimen will be treating. So previously, if they are previously treated, which means in recurrent TB or treatment after failure, treatment after loss to follow-up, sometimes follow-up will be missing, or any other previously treated clients, they will also again treat from 2+4. So this is what the methodology they should follow. So what is the community nurse responsibility? We have seen about the nurse's responsibility in the clinical settings. What is the community nursing setup? So as I said earlier, prevention is better than cure. We need to actively identify the cases through campaigns like health education program and outreach programs and mobile clinics. The nurse, primary health center nurse will be visiting the patients. What are the symptoms we have discussed already? They will be scrutinizing the patients and identifying any abnormal weight loss or experiencing the jaundice symptoms. They are experiencing any other symptoms like droplet symptoms, cough, sneezing, and continuous cough for more than 6 months. These will be identified and detect, and those will be put on for the diagnostic purpose. So the mobile clinic, they will be having a chest X-ray. Nowadays, the advanced sophistication mobile clinics are there, so they can able to take the X-rays at the bedside, clinical side, and they can go for a sputum test. And if it has been for the confirmation, they can go for a culture confirmations. So contact tracing. So it's about who are all being connected with the patients, their family members, friends, and neighborhood, and the community, which are the areas being risk to develop this particular disease. And these are about the community nurse responsibility or being our responsibility, because we are living in a society where it's also been in a community. And manage of treatment side effects, as we already discussed in detail. So the side effects should be evaluated and asked from the patients. And DOTS. So the follow-up of DOTS is in primary or been in, it is been only ensured by the community nurse by the direct visits and the follow-up. And patient education and counseling, mostly we need to counseling patient on the medications resistance to avoid from medicine misdose and their resistance drug resistance. And most importantly, community engagement program. So this is about community champion, TB champion development program. So government has initiated in order to reduce the stigma of the patients, and to reduce the patients, to encourage the awareness. They have encouraged the TB champions. Through them, they have involved. So this is a nutshell about how it has been the clinical and the community setting. When it is an ICU, you need to check for isolation and the critical care monitoring. When a patient is coming for an OPD, it should be diagnostic support and treatment follow-up. And if it is in community, we need to monitor for the adherence of the medication usage and tracing and the educations. So this is all about bedside nurse's role and the clinical nurse role. So what about the challenge in a particular, why we are facing challenges to reduce TB or eradicating TB till we have strict policy of 2025 to eradicate. So the social stigma is one of the major concern and poor adherence to the treatment and resource limitations. So these are the major changes. And what are the opportunities? Why are we are discussing this particular topic today about nurses' role? So the leadership of nurses and strengthening community engagement. These are the two opportunities which we can able to challenge or give challenge to these particular areas. So when it comes for nurses leading prevention and advocacy, promoting TB prevention strategies. While we are been giving lot of advertisements for everything, HIV there are a lot of advertisement. While we are been very less number of advertisement for TB eradication program. We are been spending much and much amount, nearly 4,000 crores project. However, there is an advertisement and outreach of this particular program is very very less. We can do it in hotels and cinema theaters like that. So likewise, you can also share some strategies to promote or prevent TB. So advocating for TB cases, there are still hospitals isolating the patients have been question mark. So there is a diploma in diplomacy in taking decision making when a patient is having pulmonary and extrapulmonary cases. When a patient is on latent phase where there is no experiencing of symptoms, still we are been having a diploma to isolate the patients, or due to the lack of bed, we are been still putting the patients in a common area or been putting in a single room without negative pressures, which is also been putting in high risk for the patients to contaminate or cross contaminate for the infection. So where we need an advocacy as a nurse to advocate for reducing the TB. So reducing the social stigma, still there are some of the states patients, the TB patients have been the arranged marriage, the marriage which has been arranged have been withdrawn, and some of the patients have been divorced after identifying, and they are being separated from their family, children, and their community, and some of them were been started suicide. So these are the areas nurses education and their awareness programs are very very important. I really appreciate Albin for taking this program. Even we have been completed in March 24. We are been providing this awareness program. He is putting and taking efforts in conducting through Nurseslab in 28th March. I really appreciate Albin for this taking initiative for doing this. So these are the areas the nursing leadership has been very much important. So empowering nurses to end TB, we are the key persons, and we are being what I can say, we are the cornerstone and we are the backbone to eradicate. Without nurses, government of India or any other program, NGOs or non-NGOs, I'm sure we cannot eradicate this program even after 2030. So the human resources should be allocated and funds should be more allocated for the nursing manpower, and nurses should be actively involved to eradicate this program. So these are about thing, and I'm so sorry I have been crossed my timeline. So any discussions or any other questions we can have, and you are most welcome to share your ideas in chat so that I can also learn from you. This is about learning from each other. Thank you so much for the opportunity. And ending TB is not just an aspirational, it is achievable. Yes, together we can end TB. Thank you so much.
Thank you, sir. That was a very informative session, and a kind request to all the participants, if there are any questions that you have regarding the topics that been shared, kindly mention your queries in the chat box, and along with the speaker's name, so that they will know that when to answer your questions towards the end of the session. So I would now like to welcome our second speaker for this evening, Mrs. Relu Sanjo, who will be speaking on the topic TB Diagnostics 2026, what every nurse should know. To introduce Mrs. Relu, she's currently working as an associate professor, PES Institute of Nursing, PES University, Bangalore, with over 11 years of academic and clinical skills in critical care, teaching, and research mentorship. Ma'am has contributed to institutional excellence and advancing PhD research pursuits. We welcome you, ma'am. Over to you.
Thank you. Am I audible?
Yes, ma'am, you can go ahead.
Yes, ma'am.
I hope my screen is visible to everyone.
Yes, ma'am.
Thank you so much. Good evening to all once again. So I will be discussing on the tuberculosis diagnostics, and which is being recommended in the year 2026 by the World Health organization. So what every nurse must know. So before moving on to the diagnostic test, just to give a brief overview about what is this all about, the recommendation which is given by the WHO, that WHO on the World Tuberculosis Day, they were trying to streamline or give certain guidelines on the new diagnostic test that can be used in the form of near the point of care, or it can be more used in the form of tongue swabs, which through which the molecular test will be used for detecting the tuberculosis disease more in a faster region. So before moving to the new innovations, I just want to brief about the commonly used diagnostic tests which are being used. So when we see the tuberculosis diagnostic test, it is mainly divided into two main categories. I think everybody knows about that. So first is for test for the latent infection. This is basically talking about the involvement of the immune response. So in that we have two tests, that is tuberculin skin test and the interferon gamma assay test. Okay, so tuberculin skin test, can anybody tell me what is the common medication we use for the administration of the for the tuberculin skin test? If anybody can tell me, or you can just put the message in the chat box also. I hope everybody is aware about the PPD, that is injecting about the purified protein derivatives for the tuberculin skin test. So I will be discussing about in detail about this skin test in the forward slides. For the test of active diseases, that is especially for the bacteriological evidences, so we usually use the sputum culture specimen collections, or we use the AFP, that is acid fast bacilli smear examinations, and so on, for the for assessing the bacteriological presence, that is especially for the Mycobacterium tuberculosis. Now, when we look the complete diagnostic test for the tuberculosis, we divide them into following components. So I have divided into 5 components, starting from the history, the physical examination, which we all of us know, and followed by the tuberculin blood test or the skin test, then chest radiography and bacteriological examination.
Sorry, ma'am. Sorry to interrupt. I think your slides are not moving. We are still in the first slide.
Can you see now, ma'am?
Yes, we can. If we can put it in the slideshow, would be better, I feel.
Yeah. Can you all see? I have shared that slide share only. Is it visible to everyone?
I'm
Yes,
not sure
ma'am.
whether it's just for me. It's not in the slideshow as of now, but the slides are visible. It's fine, ma'am.
Okay, okay. What about the others?
Still, it's
Ma'am,
not
it
being.
is-
Yeah.
Is the slide visible?
Yeah, its slide is visible, but
The slide is visible. Yeah. It's not in the slideshow.
Slide is visible.
Okay. Shall I continue?
Yes, please.
Okay, so as I was talking about the different 5 components for assessing or evaluating for the tuberculosis disease. So first we will just have a little brief about, I'm not going in detail about the diagnostic test. So the tuberculin blood test, especially here, we will be using the interferon gamma release assay test. So this is basically to identify whether the person is being infected with the Mycobacterium tuberculosis bacteria. So this test will be measuring the immune response to the tuberculosis proteins which is present in the blood, or especially in the blood components. So this interferon gamma release assay will be explaining, or it will try to mix the blood samples with the peptides, which will again try to stimulate the antigens. So especially this will be used with the control derivatives or the reagents, so that it will measure the level of interferon gamma release assay responses. So the amount or the level of interferon gamma release assay will help us to identify whether the person is, or the patient is being infected with the tuberculosis bacteria. So that is about the tuberculosis blood test. So moving forward to the tuberculin skin test, I hope everybody is aware about this Montague's tuberculin skin test. So here we have 3 steps, or 3 steps of process or procedure. First is the administration of the, or the injection of the PPDs, and followed by we will be assessing about the certain readings or the induration which comes in mm. So followed by we will be interpreting it. So as the amount of the mm or the millimeters of the inches of the induration comes in, we will be basically assessing it with the help of meters, so that we will be able to assess how much of particular. I hope the slide is moving. Everybody can visualize it.
Yeah, slide is
Yes,
moving.
yes, ma'am,
Yes.
you can go ahead.
Okay. So I was talking about the interpretation. So here, when you see towards my right side, the induration, it can be more or equal to 5 mm. So we consider it as very positive. And when we come to the downwards induration, if it is more than that, again, it will be considered positive based on the certain criteria. So basically here in this tuberculin skin test, after the administration, we will be inspecting the site, then again palpating it, marking the induration based on the readings and seeing the presence of erythemas and so on. Based on that, we will be interpreting it and according to the categories. So this I have got it from the CDC, how they administer it, how they read it based on the inspected site, and how the interpretation takes place. Followed next is the chest radiograph. So chest radiograph, basically it is to differentiate between the latent tuberculosis disease and the active tuberculosis disease. As sir has already mentioned about what is this latent tuberculosis and the active tuberculosis disease. So this will, once the patient has got the positive results with the help of tuberculin blood test, I mean with the help of interferon gamma assay or with the tuberculin skin test, followed by we will be doing the chest radiograph. So this will help us to understand about the
Ma'am.
abnormalities which are being present in the structure of the chest, especially the size, shape, density, the cavities, or any type of consolidations or lesions present will be able to identify. So when we do this, or when the chest radiographic examinations are being done, it helps us to even differentiate the type of tuberculosis which already sir has discussed. So this is about the chest radiograph, followed by bacteriological examination. So when we talk about here bacteriological examination,
No.
so
Ma'am, the next slide is not visible.
is it visible
Yeah,
now?
it's visible now, ma'am.
Okay. So bacteriological examination, the first one is specimen collection, how we collect the specimen, how we transport it, and how we process it for the further examination. The second test is AFP smear examination or the acid-fast bacilli, followed by the direct detection of the Mycobacterium tuberculosis. In this we will be using the nucleic acid amplification. Especially this is a battery generated or battery powered test which will help to identify the DNAs or the resistance towards the Mycobacterium tuberculosis. Then next one is the specimen collection and the identification of the Mycobacterium tuberculosis and drug susceptibility testing. So first we will be seeing, is the slide moving now?
Yes, ma'am. You can go ahead.
Okay. So next one is specimen collection, transport, and processing. I hope as health professionals or healthcare professionals or as nurses, we all know how we have to collect the specimens, how we have to seal it, what are the procedures we normally follow it. This is especially a sterile procedure where we try to basically make sure that it is not contaminated to the next person or the next individual or the patient. So this here, the patient will have at least 3 consecutive sputum specimens, which has to be given for the examination in the duration of 8 to 24-hour intervals. So this has to be collected every early in the morning. So once we collect this, we have to make sure that since it is an airborne infection, the isolations, the as I said, the procedure for sputum collections, and also it should be in a proper, well ventilated area. Next one is AFB smear classification or test, that is acid fast bacilli. So here basically this is done on the smear is being taken and it is being assessed in the glass slides with the help of the microscope. So here we will be assessing the presence of Mycobacterium tuberculosis, because this is one of the kind of the classification or the examination which we do it within the 24 hours of the specimen collected. Next one is direct detection of Mycobacterium tuberculosis. So here we will be using the nucleic acid amplification, in short it is NAA test, for determine the DNA and RNA segments which are being very easily detected with the presence of Mycobacterium tuberculosis. So this will be taken it in a week or more for detecting the tuberculosis bacteria, especially in the culture media. So the CDC recommends that this testing should be performed at least in one respiratory specimen from each patient with symptoms of pulmonary tuberculosis. So they have given 2 criteria for the same. One is a diagnosis of tuberculosis disease, which has to be considered but has not yet been confirmed. The second one is the test result would alter case management or TB control activities. For example, like contact investigation. So suppose if it is a false negative or it is a negative, or still there is a query of the particular tuberculosis disease. So in such cases, CDC recommends to use this type of nucleic acid amplification test for detecting the exact Mycobacterium tuberculosis presence. Next one is specific culture and identification. I hope everybody is able to see the slides moving.
Yes, ma'am.
Next one is the specimen culture and the identification. So this, as universal thing, it is considered as one of the gold standard for the culture and sensitivity for detecting the tuberculosis disease. So here the specimen will be cultured. So here two important things we have to remember is, one is if it is a positive culture, that is the confirmation for the diagnosis of tuberculosis disease, and if it is a negative, so that sometimes it can be a false negative or a false positive. In such cases, again, we may have to go for the further investigations for confirming the presence of Mycobacterium tuberculosis. Next one is drug susceptibility testing. This will help basically before starting the treatment regimen. So this test will help us to determine which drug is more effective in combination of the treatment regimen, or when before starting the treatment for the tuberculosis diseases. So here, growth-based drug susceptibility testing, here this will be done in two mediums. That is, either it can be in the liquid medium or in the solid medium. So both the results has to be particularly informed. It has to be documented. Based on that, the appropriate name of the drugs or the appropriate drug or the treatment regimen has to be given to the particular patient or the person who is being infected with the Mycobacterium tuberculosis. So these are the common investigations till now we were being normally where we were being using it. So as per the WHO, on the occasion of the World Tuberculosis Day, they have set some guidelines for the three new investigations or the diagnostic tools. One is near point of care test with the help of molecular based operated based test. The second one is tongue swabs, and the third one is sputum pooling. So I just wanted to discuss about these three. So first one is near point of care nucleic acid amplification test. So this is basically a swab based molecular test which consists of a battery powered instrument. So this will be helping us to give these swab test in the results come in less than 1 hour. So this test basically can be used in any of the primary healthcare centers, so that the smear microscopy or it can be easily done, and easily the patient will be able to detect or will be able to get the result for the same. So since it is battery powered instruments are being used, so will be giving the more, I think the slides are moving. Can you all see this?
Yes,
ma'am.
So here, as it is mentioned, there are 4 steps. So one is sample collection. First, we have to collect the sample, followed by they prepare the sample by adding the into the reagent cartridge, followed by there is an amplifications where this device will be detecting, and there will be an interpretation. So if immediately within less than 1 hour, the patient will be able to see the result on the screen. So here the advantage is it is a very rapid test, it is accurate, and on site this type of diagnostic test can be performed, especially in the peripheral health centers or the primary health centers. That is about near point of care molecular test. Second one is low complexity automated nucleic acid amplification test on tongue swabs. So here also they will be using the sample collection, especially those patients, those who are not able to produce the sputum by themselves. So this will help us to swab the patient sputum from the patient's tongue, place the sample again in the reagent cartridge, again send it for DNA or the RNA amplification based on the low complexity amplifications, and then the results can be seen on the screen. So this is also, this two test is very quick and easy, and as per the World Health Organization, they recommend that it is the most higher accuracy diagnostic tools which can be used on the on-site diagnostic itself. And the third one is pooling of sputum as a diagnostic strategy. So sputum pooling, as you can see in this picture here, you can see multiple sputums are being taken from several individuals. This is being mixed and tested together to basically, to improve the efficiency related to the sputum test. So this is also a cost constraints particular strategy is used. So here there are two-step process. So you can see here, once a swab is collected, total 4 samples has to be collected. So up to 4 sputum samples will be collected. It will be individually processed and then it will be combined in the form of pooled sample. So this pooled sample will be again used to the automated nucleic acid amplification test. So the interpretation how it is, if the pooled sample is negative, then all the contributing samples will be negative. But if the pooled sample is positive, then again each individual sample has to be retested to for which the tuberculosis is become positive or the particular microorganism has become positive. So as you can see here in this picture, if everybody is able to see, so one is collecting the sample, then again pooling the sample, giving it for the amplification, and here it will detect if it is a negative or a positive. If it is negative, then there is no again retest for the same. But if it turns positive, then each individual sample has to be tested again. Okay, so these are the 3 important diagnostic tools. The WHO recommends the further guidelines in their further modules, which has to be confirmed, and the steps which has to be completely followed. That still the recommendation is on process. So these are the 3 important newly developed diagnostic tests which they have been announced or they have been formulated based on the tuberculosis day. So that is near point of care test, that is molecular test, tongue swabs, and the sputum pooling. So when we talk about all these newly diagnostic or new innovations, what is most important here is, as already sir has explained about what are the important nurses' role. So especially during the sample collection, as I already told, the sterile procedures or the techniques has to be being followed when we do the tongue swab or when we do the sputum pooling or handling of the sputum. This is basically for ensuring the accurate result for detecting the tuberculosis. The other one is patient education. So these newly diagnostic tests or about the information which is related to all these tests has to be circulated or informed to the patients or the individuals or the people in the community based on the any of the surveillance program or the survey program, so that it is easily reachable to the patient for easy accessibility. Third one is about the rapid result management. So as I said, these all test or the 3 tests can be results can be got within less than 1 hour. So this will help us to early detect it, early screen it out for reducing the further transmission. And fourth one, I wanted to tell about equity in care. So all these, basically these 3 tests or whatever tests we do, it will be more helpful for our vulnerable group of people, especially the children's, the elderly patients, the patients those who have come across with the hepatitis or HIV, or to the rural communities or the rural people. So this test, when we address it in a proper way to the rural communities through health educations or the survey programs or through awareness programs, it will be easily available in the primary health centers as well. Next is about infection control, basically maintaining the standard precautions for how we are handling the samples during the specimen collections, transporting it while processing. It is very important for both healthcare professionals as a nurse and also for the patients for further transmission or further further prevention of infection. So I hope I have made it clear to everyone. Thank you.
Thank you, ma'am, for the detailed session on TB diagnostics. Without further ado, we'll move on to the next speaker. Our third speaker for this evening is Dr. Vasantha Gurusamy, Assistant Professor, Department of Acute and Tertiary Care Nursing, School of Nursing, University of Pittsburgh, USA. Ma'am will be speaking on the topic Nursing Implication in TB Treatment Regimens. Ma'am holds a PhD in nursing from Annamalai University, Chidambaram, and MSc in Med-Surg Nursing with specialization in cardiothoracic nursing from Father Muller College of Nursing, Mangalore. With over 22 years of experience in the field, ma'am has also participated in various research activities and has various publications in renowned journals. Ma'am has also been a speaker for various national and international healthcare conferences. It is an honor to have you here with us, ma'am. Thank you, and over to you.
Thank you so much. Good evening, everyone. I'm really happy to, talk on behalf of World TB Day 2026. And, the tuberculosis remains a major global health challenge, and effective treatment requires a strong commitment from all healthcare team members, especially nurses. And just today, I'm going to briefly discussing about the treatment regimen and what is the role of nurses in, tuberculosis management. I'm sorry. Yeah. So you all know very well, like from my two previous speakers. So you were, dealing about the role of nurses in the community and the hospital, and as well as about the detailed description about the diagnostic standards, the new ones, and the latest development in the diagnostic technology, and everything is done by the previous speakers. And I know that you have all have, known about the tuberculosis and its management. It's just a brief introduction. It's a chronic infectious disease caused by Mycobacterium tuberculosis. It's acid-fast bacilli. It affects primarily the lung, and sometimes even it goes to the extrapulmonary regions like kidney, spine, and lymph nodes and brain. So we have two different types, that is latent and active. By the name itself, the latent one is, they are positive, but they are inactive. Because of their immune system, they are able to, overcome with the immunity and antigen antibody reactions. So they are not having any symptoms and things. But in case future, if there is immunocompromised status happens in their life, or the environment is not suitable, there is a chance to become active 5 to 10%. Whereas active tuberculosis is they are positive, and they are the organisms are causing symptoms because they are the immunity is low. So where they have show the signs and symptoms of tuberculosis. And the incidence, the speakers were describing about the incidence and prevalence. Since 2000, we have 83 million people were saved by the treatment modalities and strategies. 10.7 million people, fell ill in 2024, and 1.23 million people died due to TB in 2024, even in spite of so much development and treatment. One person dies every 6 minutes from TB, and many TB affected households, they experience a lot of health expenditure. TB is driven by social, economical, and structural inequities, and continue disproportionately affect the poorest countries and people and most vulnerable population. Again, it's like a global burden. 2023 we have 10.8 million cases and 1.25 TB related deaths, and nearly 410k susceptibility, multi-drug resistant and rifampicin resistant tuberculosis case detected. Nearly 87% drug resistant TB treated, treatment success gap is present. TB remains the world's leading infectious disease killer, and the common 8 countries like India, Indonesia, China, Philippines, Pakistan, Nigeria, Bangladesh, and Congo. These are the countries contribute nearly 66% of global burden. Usually, the tuberculosis is having HIV co-infection. 6.5% of all TB cases have this HIV infection. Both are occurring simultaneously, and 8,300 cases reported in 2023 in US, and this is especially among the foreign-born persons, nearly 70% of cases. So this is the WHO's report, and the global burden based on India's 25% of all global cases are from India, and India is number one highest burden country. 2.7 million estimated cases are in 2024. India has less than 18% of global population, but we bear 25% of global TB burden. And key risk factors why in India we have high risk, it's because of undernutrition, diabetes, and HIV co-infection, smoking, it's because of overcrowding, and it might be because of poverty. So the World TB Day 2026, yes, we can do and end the TB, led by countries and powered by people. Every $1 invested in TB yields up to $43 in returns. That means when we, act in preventive measures, especially in controlling or containing the TB, so that, it helps in, we don't have to manage the patients with treatment and multiple drugs, diagnostic tests, and so many, so that we get the return of $43. So its prevention is always better than cure. India has the world's largest TB laboratory, and treatment success rate now is 90% above the global average. So still we are, we are in the highest range of treating and controlling the tuberculosis comparing to other countries. And collective action across sectors is a key. So there should be a collective action should be done by the government and non-governmental organizations and all healthcare team members to control and implement this. So today's learning objective is identifying the first line and second line TB regimens. Already there were brief description given by the previous speaker, and describing the nursing responsibilities in the TB and DOT programs, and recognizing and managing the adverse reactions, applying strategies for improving patient adherence and treatment completion, and differential drug sensitivity and drug resistant management, and outlining the infection control in the hospital or in the community. So the overview of treatment, what's the aim of treatment is, one is to cure the patient and prevent the death, prevent the relapse in case if the patient has become latent, and to prevent the relapse and prevent resistance and interrupt the transmission. That is our goal. And the key principles of TB chemotherapy is use at least 2 effective drugs. There are combination of many drugs it should be given, so we have to at least use combination of 2 effective drugs. Avoid adding a single drug to a falling regimen. If there is a problem with a particular regimen, it's not that adding or deleting any single drug. It should be overall the regime of the drug should be checked, and it should be changed together. And implementation of direct observed therapy, that's a DOT therapy, that should be implemented, and it should be encouraged to adhere. Monitor for toxicity and regularity, and completion of full treatment even after the symptoms improve. So maybe after 2 weeks or a month, maybe the patient feels improvement, but still we have to encourage to continue the treatment, maybe either 4 months or 6 months according to the treatment regimen. The phases of treatment, there is in intensive phase, that is first 2 months, and then continuation phase, that is 4 to 7 months. So this intensive phase has multiple drugs to quickly reduce bacterial load, whereas in continuation phase we have fewer drugs to eliminate the remaining bacilli, like we don't want it to relapse. Okay, so the new regimen is, there are only 4 months, and there are something like 4 months and 6 months regimens. 2 different regimens are available. Just we'll see that. Okay, so according to the treatment availability, number 1 is drug susceptible TB. What is susceptible TB? Like the active organisms are responding to the treatment. This is to the tuberculosis organisms. So that is like 2 phases, intensive and continuation phase. The intensive phase is like 2 months of treatment with isoniazid, rifampicin, pyrazinamide, and ethambutol, and continuation is remaining 4 months where they treat with isoniazid and rifampicin only. So this is the regimen of standard 6-month regimen. So there is the short forms like HR, ZE, and HR. This is like indicating the drugs. Okay, so the isoniazid is indicated H, and rifampicin is R, and pyrazinamide is by pronunciation is Z, and ethambutol by E. So this is like the short forms used. So the first choice is 6 months treatment, 2 months of intensive, and 4 months of continuation treatment. The second modification is the newer one is only 4 months regimen. We have 2 months intensive treatment and 2 months continuation of treatment. The 2 months intensive treatment have isoniazid, rifampicin, and pyrazinamide, and moxifloxacin. Instead of ethambutol, we are changing this drug. So it's only 2 months. It's more effective, and it's short duration. So the patients are easy to adhere. And then continuation, again 2 months, that is isoniazid, rifampicin, and moxifloxacin. So this is again for following 2 months. First 2 months is actively they're destroying all the bacteria, and the second 2 months, so it helps to contain the remaining bacteria, so that the patient is completely out of the infection. And then for children, there is a 4 months regimen. There is not for non-severe TB. There's intensive and continuation phase each 2 months. The intensive phase has isoniazid, rifampicin, pyrazinamide, and ethambutol, and continuation is isoniazid and rifampicin. So this is recommended by CDC and American Thoracic Society. So all this based on 2025 is a latest recommendation. So overall, the standard drug susceptible tuberculosis treatment regimen, which has has isoniazid, rifampicin, pyrazinamide, and ethambutol, it rapidly reduces the bacterial load and eliminate the drug susceptible organisms. That is in the first phase. And the second phase, it eliminates the remaining persistent organisms and prevent relapse. That is isoniazid and rifampicin. So what is the thing which we have to keep in mind? So totally it is 6 months. It's a drug sensitive pulmonary tuberculosis, and extended to 9 months in case if the patient has extra pulmonary infection, like in the central nervous system, tuberculosis and the bone and joint TB or severe pulmonary disease. So it can be 9 months. Pyridoxine should be given with isoniazid to prevent peripheral neuropathy because it's a common side effects, and ethambutol may be discontinued once susceptibility to isoniazid and rifampicin. So if the treatment is effective by isoniazid and rifampicin, then can discontinue the ethambutol to reduce the side effect of ethambutol. So new 4-month regimen, so that is rifampicin based, approved for eligible adults. So they can follow instead of rifampicin, the rifampicin can be included in the regimen, and then it can be continued only for 4 months. So this is a newer update. And there is a latent TB infection. So, that is active, the one which we saw. Next one is latent TB infection. If the patient has, inactive TB, but still, the patient is having the immunocompromised status and there is a risk of developing TB if is expected, then the patient can take this isoniazid for 9 months. It's a gold standard, and isoniazid plus rifampicin for 3 months, weekly dosing, and shorter it is more preferred. And isoniazid plus rifampicin 3 months alternative, where the previous one is not possible or unavailable, that is the isoniazid and rifampicin is unavailable, then it can be with this rifampicin can be taken. Drug resistant, in case if it's a drug resistant, maybe if the person is not responding to our first line treatment, so then we can go for the second line medications, that is B-fal-M, that is betaquilin, pretomide, and linezolid, and moxifloxacin. So this is 6 months treatment can be given for the patient, and then if not, there is an alternative, another 6-month regimen where there is only like betaquilin and then pretomide and then linaloid, only these 3 drugs for again 6 months. So this is in case if the patient has resistance to this fluoroquinine resistance or intolerance to this drug, so then they can follow this B-fal instead of moxifloxacin. Extensive drug resistance if present, then they can go for resistance to isoniazid, rifampicin, or at least 1 fluoroquinine and 1 injectable agents, so can be followed. It is if the treatment options are limited and mortality is high. This is approved by FDA in 2019. It's a key drug treatment. It's individual based. So each individual patient supposed to be monitored, and then their the diagnostics based on their diagnostic test and based on their weight, based on their COPAP, nutritional status, and all those things. So they have to decide like which type of treatment to be taken by the healthcare professionals. And the last one is MDRB treatment regimen, where the newer option is unavailable. So this is very long or extensive, like 18 to 24 months. It includes betaquilin and injectable agents. So injectable agents, it can be like amikacin, kanamycin, capreomycin, and streptomycin. So this can be added along with companion drugs. The companion drugs are like ethanamide or cycloserine. Any of these drugs can be given together along with betaquilin. So this is less injectable drugs and this type of treatment, that is the last available treatment. This one is less preferred due to the toxicity and longer duration and low success rate. So this third category, that is drug resistant tuberculosis, only if the patient is not responding to the first line drugs, so then we are going for this type of drug resistant regimen. And so what is this first line drugs? The first line drugs are the drugs which is helps to acting against Mycobacterium tuberculosis, and it helps to control the antibodies effectively with less side effects, and it helps to reduce the bacterial load. So the first line medications are isoniazid, rifampicin, pyrazinamide, and ethambutol. So the side effects, like we must know as a nurses, we should know the side effect of these medications in order to monitor the patient and treat. Like in case if the isoniazid is given, so there is a damage, hepatotoxicity, so monitor the liver function test and then give pyridoxine, so to replace the vitamins and avoid alcohol. Check the status, blood levels of this isoniazid. And rifampin, it's warned about body fluid discoloration. So as it was already told that leads to orangish discoloration of body fluid. So it should be told to the patient, and it is expected. So it's not causing any problem to the patient. It should be informed to the patient. And pyrizinamide, so it leads to hepatotoxicity, and there is a problem with uricemia and arthralgia. So monitor the uric acid, liver function test, assess the joint, and it should be taken with the food if the GA upset is present. And if the patient is pregnant, it should be avoided. And ethambutol, so 15 to 20 milligrams, and it should be given. Baseline and monthly visual acuity should be checked, because ethambutol has a problem with optic neuritis. There is changes in the color vision, so report any visual changes immediately. Avoid in young children's because they cannot report. And newer and second line drugs. So second line drugs are the drugs which chose in case if the first line drugs are not not responding, and the it's not effective. Patient is not able to cope up with the first line drugs. So the second line drugs are also act against this Mycobacterium tuberculi, but this is having more toxicity and more side effects. So always we'll prefer to go for this first line medication, and then if not responding, then we are going for the second line medications, that is beta-quilin. So the dosage is this much, and then the 400 mg per day for 2 weeks, and 200 milligrams 3 times a day per week for 22 weeks. So what's a problem with this? This is a drug which causes QT prolongation. It's most serious, like leads to cardiac problems. So hepatotoxicity, nausea, and arthralgia and headache. So this we need to be careful if the patient is taking any other drugs like for cardiovascular pathology or disease conditions. So we need to be careful. Should not be given to the patient. In case if it is given to the patient, monitor the ECG. This is a nursing responsibility for weeks 2nd, 4th, 8th, 12th, and 24th. Discontinue if the prolonged QT interval is present, and monitor and correct electrolyte imbalances before and during the therapy. Avoid concurrent use of other QT prolonged medications along with this beta-quilin. And monthly liver function test education on the signs of hepatotoxicity should be done. Document and report palpitations, dizziness, and syncope. So need to teach the patient about the signs and symptoms of side effects. In case if the patient feels any side effects like palpitation, it's supposed to be reported on time. Next second line drug is pritomanid. This is a dose of 200 milligrams per day, and it causes peripheral neuropathy and hepatotoxicity. Even it leads to QT prolongation and anemia. So because it's a neuropathy, it needs to neurological assessment in the each visit. Monthly liver function test, ECG monitoring to be done, must be administered under the specialist supervision only. Monitor CBC for anemia and educate the patient on signs of neurotoxicity. Okay, so is that okay? So the next one is linezolid. This is 600 milligram per day, and the adverse reaction is myelosuppression. So there's a chance of getting pancytopenia, and then thrombocytopenia, optic neuropathy, and serotonin syndrome. And lactic acidosis. So nursing implication is weekly CBC for the first month, then for monthly, and monitor for the pancytopenia. Monthly assessment of peripheral and optic neuropathy to be done. Absolute contraindication with MAOA uptake inhibitors and serotonin inhibitors, like especially if the patient is taking any antipsychotic medications for depression and psychosis. Need to be careful, and it is a contraindication. It should not be given. Educate the patient on signs of infection like neutropenia and bruising and thrombocytopenia, because it's a myelosuppressive medication. And dose reduction and drug change if the toxicity develops. So in case if the signs and symptoms of toxicity have been reported, the dose should be reduced, and the change of drug can be preferred. Moxofloxacin, this is 400 mg per day. This also leads to QT prolongation and GI disturbance like nausea and diarrhea, tendinopathy like Achilles tendon rupture, and there's a chance of getting a musculoskeletal problem, photosensitivity and CNS effect. So as a nurse, we need to monitor the ECG to see whether the patient has a QT prolongation, and the musculoskeletal assessment to check for Achilles tendon rupture, and warn the older adults about this risk, avoid in pregnancy, and advise on sun protection because there's a chance of getting photosensitivity. Okay, direct observed therapy. So this is very, the effective treatment, which is helping for the patients. I mean, we can motivate the patient to adhere to the treatment. So a trained healthcare worker supposed to be, watching the patients swallowing each dose of the TB medications. So the cornerstone of TB treatment, and it helps to improve the adherence globally. Why DOT is important? It ensures medication is actually taken. Like, for example, you give, set of drugs like 30 or 40 drugs to the patient and tell the patient to take. We are not sure, like, they are really taken the medications or not, or simply dump the medication at home and then they come to you and say that they have taken. But here, the patient is, you are observing that the patient is really taking the medication, so that, we need that. So to control this active, bacterial infection. They are not discarding, they are not piling, and then it's not sold also. And early detection of adverse drug reaction. Yes, every time when you meet the patient, you also observe the patient, so you know that there is any side effects or not. And it helps to build the therapeutic relationship, to identify is there any barrier to the patient. I mean, there is any cultural, social, or financial problem experienced by the person that you can understand, and prevents emerging of drug resistance. So also that exactly you identify on time whether there is any drug resistance still, in spite of taking this medication, the patient is having the signs, symptoms. That means the patient is having drug resistance, that you can understand. Required by law in many jurisdictions for infectious TB cases. Yes. And types of DOT. So we have in-person DOT, video DOT, and SMS reminders on community DOT. So in person, the patient has to directly observed by the healthcare workers. So the patient is coming to the center, or this person, the healthcare professional or community health nurse is going to their home. So where the in-person you're observing, and video where the patient takes medication via the video call. Like you make a call, so see the patient taking by the video you're assessing. So where it's possible, where internet accessible for the patient and in the urban areas. And SMS reminder, text-based medication reminder, digital tracking can be done. So especially the patient with the low literacy and remote area the patient is living, so you can do that. Tailored message can be sent to the patient, and then reminder can be sent to the patient, and the patient is taken. But we are not sure about this as a reminder. And community DOT, trained community health worker at the patient's home. So rural, directly they are going to the home visit, and they are encouraging the patient to take. That is a community DOT. So these are the types of DOT treatment. And then, so the nurse's responsibility is assess and document each observed dose. So like whenever the patient is taking, you document that, the dose, the time, the location, and patient's response, how the patient is responding. Report missed doses promptly in case if it is missed, maybe because of any circumstances, the patient has not come, or there is any difficulty. So report that to the TB program coordinator. Identify and address the barriers. So whenever you meet the patient and maintain a good IPR with the patient and address, is there any barrier is present, like transportation, working schedule, housing instability, or stigma. Because of stigma, they don't want to come and talk to you, or they don't want to take the treatment. So just identify what's the problem the patient is experiencing. Provide incentives and enablers per local program like bus passes, food vouchers, and childcare if there is a funding is available in locally from the primary health center or the community health center. And the document on standardized DOT card or electronic TB information system. So whenever the patient is coming and taking the medications are done, so you have to document electronically to know the progress, how much the patient is following the DOT. And so the next one is comprehensive nursing intervention along with this DOT and all this medications monitoring and the treatment. So what are the overall comprehensive nursing intervention? Number one is initial assessment. So before starting this treatment, so baseline vital signs should be monitored, body weight, BMI, and nutritional status of the patient, and baseline LFT, liver function test, CBC, serum creatinine, and uric acid. and visual acuity, red-green color perception, because ethambutol has the effect of toxicity, causing damage to the visual acuity, and baseline ECG before beta-quilin and moxoxyfloxacin, and HIV status, blood glucose level, pregnancy test if applicable, sputum AFB culture, drugs and susceptibility testing results, and the psychosocial assessment like stigma, depression, social support is available or not, any substance abuse if they have. So all this supposed to be done before starting the anti-tuberculosis treatment regimen, and then it should be documented. And medication administration, administer anti-drugs, tuberculosis drugs on empty stomach for the maximum absorption, or with food if the GI upset. So you have to monitor, like if the patient is okay with taking medication on empty stomach without any GI upset, so it should be given because it is more effective. But if there is a problem like nausea, vomiting, diarrhea after administering this medication, so better the next time they can take with food. Ensure observe swallowing of each dose, document every dose given. Do not crush entry coated formulation. Tablets may be crushed for children, but there is no way, so sometimes you have to. But for adults, like if they're able to swallow, they have to take it, the whole pill. Administer pyridoxine like vitamin B6 co-prescription with isoniazid routinely because it causing side effects which depletes vitamin B6. Monitoring the schedule. So first the assessment and then your administration and monitoring. So you have to monitor monthly the sputum AFB culture, and LFT should be done in the baseline and also monthly, and visual acuity and color vision baseline and every month when the patient comes for the treatment, especially on ethambutol. ECG, the prolongation of acuity interval should be done for 2, 4, 8 and 12 weeks. CBC, every week it should be done for a month. For a first month, every week it is done. Then monthly once it should be done, especially if the patient is taking on linezolid. And serum uric acid, it should be done in the baseline and periodically. And if the patient is on pyrazinamide. And body weight monthly should be checked and documented. Chest X-ray at 2 months, 5th month, and in the end of the treatment to see how effectively the lesions in the lungs have been cured. And the patient and family education, why multiple drugs? So because there are a lot of drugs, either the first line drugs, 4 drugs for the intensive phase, then again 2 or 3 drugs in the continuation phase. So a lot of medications they are taking. So you have to explain to the patient why we are giving a lot of medications, because it targets, each drug targets differently in the Mycobacterium tuberculosis, and a combination helps to prevent the resistance. And why so long? TB bacteria grow slowly, so the short courses allows a dominant bacilli to survive. So sometimes you're giving only for 2 months and then you're not taking, so still the bacteria is surviving, so there is a chance of getting relapse, so that you're giving for a long time to control, completely eliminate the bacteria. And never skip the doses, even if it's feeling better. The patient is maybe after 1 month or something, the patient might be feeling better, there is no active symptoms like cough or sputum production so much, but still you have to encourage, motivate the patient to continue the treatment. Rifampicin turns the urine and body fluids orange. It is normal, not harmful. And also avoid soft contact lenses. So if the patient is using contact lenses with the rifampicin, sometimes tears, it stains the contact lenses, so it's a problem. So ask the patient to use the spectacles. Avoid alcohol because when the patient is on this medication, so the substance abuse supposed to be avoided, like especially alcohol, because already these drugs have the hepatotoxicity. So to reduce the hepatotoxicity, we have to encourage avoiding the alcohol, and report immediately in case if the patient has jaundice, visual changes, tingling and numbness, palpitation or any symptoms, so supposed to be reported immediately. Half hygiene, so encourage the patient to have a half hygiene, like cover the mouth, use the tissues, ventilate the rooms, stay home until the non-infectious. The patient's not supposed to go to the work or anywhere public places to prevent the spreading of infection. Nutritional guidance like high protein diet should be taken, high calorie diet, and avoid very fatty food to reduce the GI upset and symptoms. And contact tracing, household contact should be screened for the tuberculosis. If a person is affected in a family or in the community, so they have to be, all other people have to be screened for the active infection or the presence of infection. Nutritional support, Malnutrition is a leading risk for TB in India, also slows recovery. So high protein like 1.2 to 1.5 grams per kg and high calorie diet should be advised. Government of India doubled the Niksha Poshan Yojan, that's a nutritional support program in November 2024. They started so that along with the DOTS therapy, the tuberculosis therapy with free of cost of medication and this nutritional supplement program will help them to have, compact the infection and improve the patient to completely eradicate the bacteria. And nutritional support to the household contact to reduce the TB mortality by 50% and incidence by 40%. So if you give the nutritional support to the people, so you can reduce the mortality and incidence in the overall household, and referral to dietitian for the patient with significant weight loss or severe malnutrition. In case, so when you are assessing the patient monthly, so you know that the patient is having significantly reduced weight and there is a symptoms of malnutrition, so that person is supposed to be referred to the dietitian to have a proper diet plan and for any nutritional supplement treatment. And psychosocial support, TB carries significantly stigma. Patients may face social isolation and loss of employment. Yes, if they are positive, so the people may, segregate them, and maybe in the workplace they may not be, employing them. Even in the hospital, like you have your screening test should be done, pre-employment checkup to be done in case if it is active, so not be implemented because the person is not working because there's a chance of getting infection. So there is a stigma. So it's supposed to be the patient, the family member is supposed to be educated and how to prevent the active infection, how they can protect themselves. All this supposed to be, given. The information should be given to them and talk to the patient, allow the patient to ventilate the feelings and reduce the depression and anxiety and the baseline and follow-up visits. So allow them to, talk to you how they are feeling and how is their family support and social support they have and what's the problem they are experiencing. So you have to talk to them, and if they're very comfortable and psychologically stable, so it helps to adhere to the treatment further and they can come out of this infection. So involve family and peer support system. Peer TB survivor counseling should be given. Address a financial hardship linked to the social welfare programs if there is any available program. If they are in the need of any financial help, then you need to advise them to link to the social welfare program. Provide psychological support to reduce anxiety and improve adherence. Yes, and that's about the psychological support. So the special population, so this is about the overall nursing management. This is for the special population, like if the patient has a HIV infection along TB, so we have to have, coordinate timing of ART, the antiretroviral treatment, like antiviral treatment for HIV and TB treatment based on the WHO recommendation, and monitor for the immune reconstitution and inflammatory symptoms, enhance the psychosocial support due to the dual stigma. The patient has HIV as well as tuberculosis, and in case if the person is having pregnancy, so ethambutol and rifampicin are generally considered safe, okay, and avoid pyrazinamide in the first trimester if possible, because that has a chance of producing fetal, toxicity and malformation, congenital defects. Pyridoxine supplement is essential with isoniazid, and coordinate with the obstetrics team and monitor the fetal growth in case if the patient is pregnant. And pediatric TB, so administer weight-based dosing, so monitor the, usually even for the adult, so we have to monitor the weight, but especially they are more sensitive, so pediatric, they have to be weight-based dosing and reassess the weight monthly, adjust the dose according to the weight, and use a child-friendly formulation available, like if they're having difficulty in swallowing pills, if there is any other like suspension, oral suspension, syrup, or any other friendly formulation is available, that should be encouraged for easy adherence to the treatment. 4-month regimen now available for non-severe TB in children, and involve the patient, parents and guardians in the DOT treatment and education. And substance use disorder, in case if the patient has already the alcohol use and hepatotoxicity with isoniazid and rifampicin, so need to be monitor for the patient's hepatotoxicity, and rifampicin significantly reduce the methadone level and monitor for the withdrawal. So it is advised, okay. And video dot preferred for the patients with the unstable housing. If the patient is having, unstable housing, integration with harm reduction services improves completion rates. So if there is a unstable housing integration, or if there is any problem like that, so video dot can be performed instead of meeting the patient directly, and give psychological support and encourage the patient to adhere to the treatment, and use the family support system to make the patient to adhere to the treatment. And TB infection control and hospital and the community. So administrative control, like a written TB infection control plan should be there in the hospital. An annual review should be done. Early identification and triage of suspected TB patient. Prompt airborne isolation, that is negative pressure rooms supposed to be there in the hospital, especially if the patient is active tuberculosis, supposed to be having the negative pressure rooms. Medical evaluation and treatment without delay should be done in the hospital. Healthcare worker should be have annual TB screening should be done. So either IgR immunoassay test or TST test should be done annually. I think most of the registered nurses might be knowing this. Examinations done in the hospital to monitor their exposure to the TB, and screening to be done. And in the environmental control, airborne infection and isolation room supposed to be in the maintained in the hospital. Negative pressure and direct exhaust outdoors supposed to be there, like means from the room where the patient is there, so direct exhaust supposed to be there, so that air should not be circulated inside. And HEPA filtration where negative pressure room is available. So if negative pressure room is available, that's well and good, because this negative pressure room will not, it takes air from outside, but the air will from this room will not be, recirculated inside the hospital, the other areas of the hospital. And HEPA filter can be fixed in the room where the negative pressure is unavailable. The UV germicidal irradiation also can be used in the rooms, and door must be remain closed always, and monitor the pressure difference. So if the patient is there in the negative pressure room, so there is 2 doors in the patient room, where when you are opening the door which is open to the other floor, other rooms of the floor, so the first door, patient immediate door supposed to be closed. When you are opening that, the other door is closed. It both is not open simultaneously. You have to see that the pressure in the room is supposed to be maintained appropriately, and there should be adequate air circulation to be done every hour. Maybe 6 to 12 times the air is circulated outside, so that it is fresh. Even the healthcare person coming and taking care of the patient with proper PPE, so it helps to, because the air is circulated frequently every hour, so that the air is not having much bacterial load. So there is less risk of anybody who is coming and contacting to the person, especially the healthcare workers. And respiratory protection. So the healthcare professionals supposed to wear N95 respirators, and fit test supposed to be done annually. Consider PRP for PAP-RE for aerosol generator procedure. Like it's a powered battery system where it helps to, it's like a HEPA filter. It's like a filter which helps to prevent the infection, especially if the patient is having hood, or if the patient is, you're doing some procedure, bronchoscope, or sputum induction, some procedures you're doing for the patient. In that case, can be used. A patient surgical mask when leaving the room supposed to be done. In case if you're transferring the patient for any other areas of the hospital or outside, the patient supposed to wear the surgical mask. The visitors always encouraged to use N95 mask, and educate on donning and doffing, how to wear and how to remove this and how to discard this N95 should be taught to the family members also. And discharge criteria, 3 consecutive negative AFB smears supposed to be done, and clinical improvement supposed to be there. And also adhere to the therapy. You know that the patient is going to adhere to the therapy. If everything is verified, then the patient is supposed to be discharged. So this criteria to be checked. And then common barriers, like what are the problems, why they are having, withdrawing this treatment in between. It's because of, the pill burden. So there are so many tablets, up to 15 tablets per day, sometimes in case of, multiple drug resistance, and long treatment duration, nearly 6 to 24 months, sometimes adverse drug reaction, stigma and fear of disclosure. So they don't want to tell that they have the infection because they are worried that, other people, they just isolate them. Financial and social instability, health literacy gaps, and immigration and legal status of concern. Maybe some people living abroad, so they have problem with the, immigration and legal status. That's why they don't want to show that they have infection. So, and they don't want, if they're not showing that they have infection, so they will not be getting the treatment too. So these are the barriers. So what are the strategies by which we can help to, improve this treatment adherence? Number one is DOT, and either direct and then video DOT. It reduces treatment failure. And incentive programs. So food vouchers can be given, transportation can be arranged, cash transfers can be done if they come for the regular treatment, if the financial, funding is available. Patient education and engagement. So teacher health education and periodic education to the patient and family members can be done. So there's more some individual education can be done. And fixed dose combinations, like instead of having different doses and changing a lot of, combinations, so give the fixed dose and number of medications, so and fewer pills. That helps them to adhere to the treatment. And community health workers, they have to be more like going for the home visit, identifying their people with the problem, facing the problem, stigma and financial problems, any other problems faced by the people, to be monitored by the home visits by the community health workers. So that helps to reduce burden. And treatment supporters like family-based DOT, family people supposed to be encouraged. And then digital adherence tools. So there is called Wise Pills as electronic monitoring and SMS reminder. So can give SMS reminder and electronic monitoring can be done. Like we can encourage, like there are, it's a newer, but I'm not sure like how it is possible. So whenever the patient take the pill out of the container, so it just, go to the documentation that the patient has taken the pill. So it is done. So this is like an app. It can be, followed. That is a digital adherence tool. So this helps to improve the adherence of the treatment. So these are some strategies by which we can, encourage for the patient to continue the treatment. Monitoring and nursing checklist. So as a nurse, what are the things we're supposed to have? Like, baseline, monthly, and end of the treatment. In the baseline, so we have the documentation of sputum, AFB, 3 culture, and then chest X-ray report, LFT, BMP, CBC, uric acid, all these basic blood tests, visual acuity, baseline ECG, HIV test, HBV, HCV screening, pregnancy test, and weight in the baseline. Also monthly, like weight, LFT, sputum, and visual acuity ECG. In case if the patient is taking, beta-quilin, and symptom assessment, second line drugs, they have problem with the QT prolongation. And symptom assessment like nausea, jaundice, and vision tingling supposed to be monitored every month and documented. If there is any problem, should be notified to the coordinator. And end of the treatment, like you completed the treatment, so what are the tests to be done? Like that's sputum culture 2 times and negative for cure designation, and chest X-ray to be done, final weight and clinical assessment, documentation of treatment outcome, like whether it is cured after this treatment, end of the treatment, the patient is cured or completed the treatment and the treatment is failed, or the patient died, or the patient lost to follow up, not come for the follow-up or anything, and not evaluated, like what is the status, supposed to be documented effectively. And in case of latent TB, you need to check the close contacts if the patient is, patient is having latent TB, and the close contacts supposed to be screened appropriately to identify the number of, infected patients. And the overall recommendation for nursing practice based on the current evidence and guidelines is: number 1 is adapt and facilitate DOT for all the active TB patients in person or video DOT as the standard of care, and contact through the baseline monthly assessment include so every month need the checkup, like head assessment, like visual acuity, ECG to be done and LF to be done, and implement detailed nursing management. So it's another research study they have done. It's a framework with individualized patient education, psychosocial support, and medication safety surveillance. So this all together, this is called a detailed nursing management framework. So this helps to improve the patient adherence and treatment, and integrate technology like VDOT, SMS reminder, mHealth app, mobile health apps, especially for the patients in remote settings. It is useful, and stay current with the updated regimen. So the 4-month drug susceptible TB regimen or 6-month BPL regimen, and represent major shifts requiring nurse re-education and protocol updates. So as a nurses, we have to educate ourselves, and whatever updates are there, newer updates about the treatment regimen, about the diagnostic procedures, and whatever is followed, need to update ourselves so that we can educate the patient, and then encourage for the adherence. Address the psychosocial needs like screen routinely for the anxiety, depression, and social isolation, as these directly impair the treatment adherence. So if the patient is not having understanding the importance of the treatment and following up the treatment, we cannot, if the patient is not aware of that, then we cannot force that. So in order to attain that, need to assess the psychosocial status of the patient. Reduce the stigma through the community education and patient advocacy. Yes, so not only educating the patient family, and to the community, have to educate about the TB and how the transmission is happening, how they can protect themselves, and all those things should be done in the community level. And collaborate actively with a multidisciplinary team, including working with the nurses, are like backbone or cornerstone, you can say, in the TB treatment. So especially all these communicable diseases, so they have to work along with the physicians, pharmacists, social workers, and community health workers in order to implement the effective treatment regimen. So that's about the treatment regimen, and then about the role of nurses in treatment of tuberculosis. Hope I'm clear. So if there is any doubt or anything, please, you can proceed.
Thank you, ma'am. Due to the lack of time, we will have 3 more speakers. So we will move on to the next speaker. If there is any doubts or questions, kindly contact the speakers directly. They have shared their information through email. So we will move on to the 4th speaker for this evening.
Thank you so much.
Yes, thank you, ma'am. Our 4th speaker is Mr. Tamil Pulavendran sir, nursing tutor, National Apex Coordinating Center, NIMHANS. He'll be speaking on the topic TB stigma, mental health, and nursing communication skills. Sir is a PhD scholar from NIMHANS and completed his master's in psychiatric nursing and MBA in hospital management. Sir is a recognized awardee like the Best Paper Award, Rising Star Award in educational category, and Best Project Award, Best Outgoing Award. Sir has various researches and publications in national and international forums, and has an active national level exposure in tele mental health services, and is a trainer and resource person in healthcare services and orientation and awareness programs. We welcome you, sir. Over to you.
Thank you so much, ma'am, for your brief introduction. First of all, I thanks to our organizing team as well as participants for your patient listening. And I'm also going to talk about a simple and important topic. And you all know, see, this is like just interaction session. If possible, audience can interaction they can done. Then if you had not interaction also, I can start. So again, this topic is TB stigma and mental health and nursing communication skills. How we are handling the community communication skills in their hospital setting as well as community. How it is important. What is the importance of communication? We are going to know this session. And final this session, we have some quiz we have. That is 2 minutes. We can start.
Excuse me, sir. You are muted.
Yes, I'm muted now.
Yeah, now audible, sir.
Yeah. So in this objectives, we are going to learn mental health and TB stigma, as well as how we can connect with TB patients, as well as understanding about the patient's emotion through our communication skills, and then mental health service initiated in India. So we will going to see. So now the first slide is mental health. What is mental health? Mental health, it is given by WHO. The mental health is a state of mental well-being that enables people to cope up with the stresses of life and realize their abilities, learn and work well, and contribute to their community. And it has intrinsic and instrumental value and is a basic human rights. So we all know the person can able to contribute their community, what they want to know, they had, what their interest, whatever, that they have to contribute the community. That is a basic mental health. And then, see, according to WHO and global level, how the prevalence rate of TB patients, like, the nearly 1 billion people they have worldwide, we have prevalence, as well as so many of them have consequences like they have mortality rate high. That's what our team also, we have to end TB like that. Then TB as mental risk. See, due to the TB things. So many of them have the mental health issues like depression, anxiety, and like that comorbidity disorders are more. And then stigma and discrimination is also happening in our community. So these are the basic things. And then stigma related thing still we in our government of India, they are giving us so much things like the initiating their programs, they are providing the money for like monthly 500 rupees like that they are giving, but still they have in India like a stigma is there, like a social conditions. Many of them who have a poverty, they only get a TB like that. They have that imprisonment and migration. They who are all there in migration, they get TB easily like that. It is an infectious disease. It can easily spread. So whoever touch the patient or talking with the patients, we can get a TB like that they have. And also they have, it is a HIV co-infections also. If someone they were thinking community side, if we are talking with the TB patient, maybe I will get HIV or like that they get more stigma like that. And also many of think if I got TB, lifelong I have, or else I will die easily. Like they will think like that. So still it is stigma. It is there. So as a nurse, what we have to do? How we can use our skills. How many of you know what are the skills we have? We are using in a hospital or community wherever. So here we are in hospital settings or as community or whatever it is. We are using so many skills day by day. Without skills, we can't be able to connect with the patients. Like that's called as generally empathy. We will say. So empathy means we will understand their situation. We have to stand with their own shoes. Like that, they will say what we have. Same way the patients also they the emotions like that. We have to understand the patient. Due to for that, and also improve the communication relationship, like in the therapeutic communication, we should maintain use our skills in different way. So this what are the skills I will explain. First one is active listening. So in this, it is very important skill. How we will say active listening? How we will do? I will tell you. If someone saying yeah, they are saying there about disease conditions. I have this thing due to this thing. I have I can't able to handle like that. They will say like that. Then as a nurse, we have to say like yeah, yes, oh like that. This notes we have to give. So then they will understand. They are listening. Like as well as we have to show our shake our neck like yeah, yes, like that we have to say. This is all the active listening. Hearing what is being said and processing and interpreting the words that are being spoken or unspoken. That is a very important. This way we can do. Second one is validation of emotions. So for example, here many of them, so what they think, validation of emotion means, yeah, we are validating, yeah, you are in emotion. Yeah, okay, like that they will say. But here, very important thing is we have to understand and accepting the patient's emotion experience. Like, for example, yeah, you are due to that reason you undergone, you had some stress. I feel like that you have to say some what their emotion we have to express that one. That is very important. That is a validation of emotion. And then the empathy already told that you have to stand with their like the same way what they have we experience. So we have to talk like that. See, we should not talk like yeah, everyone has same thing only, why we are talking like that, why we are handling like that. No, if you are saying like that, you can't able to connect with the patients. That is very important. Like imagining yourself in the patient situation. That is very important. Then how would you expect others to talk to you in the same situation? That is very important. So empathy is a very big skill. That is very important. Then empathy can, the patient, they will realize our this nurse understanding about ourselves. I can talk whatever I want to talk that nurses, but it should be in boundary. Then reflection. So reflection, it is like a mirror. So the realizing what the caller or patient are saying going through. For example, I will say if person is saying I am having this kind of situation daily. I'm taking tablet, but my family also suffering like that. They are saying here we have to think their feelings. Oh yes, because of your family members handling this thing and all, you are getting sad. Yeah, if you are, I'm seeing you are very sad. Like that, you have to focus on feelings. Then only they understand. Okay, this nurse they understand what I have the feeling. Like that, they will say. Another thing is paraphrasing. Paraphrasing, it is also one of the beautiful skill. Like see here, one thing is whatever the patient is saying, whatever is the patient saying. Here we should not repeat the same thing. Here I also many of my students also when I clinical and all. whatever the patient saying, they will repeat. Yeah, okay, you have this thing, yeah, this thing, yeah. They will not like that. If you are repeating what they are saying, they can't connect with you because they won't understand. Oh, this is, they are everyone the same only. They are asking only history like that only. They will think. But here, very very important. Whatever the patient saying, the nurse should be use different word, but should not change the meaning. That is very very important. Okay, that is a paraphrasing. The paraphrasing is a repetition patient's feeling by the nurse in their own words. That is very very important. Don't repeat the same words. Okay, meaning should not be changed. Okay, next, rapport building. So rapport building usually we are doing. So this is for a therapeutic relationship purpose we are using. Then you and patient, we have to have the rapport because of they have to improve their condition. So these are all the basic skills. I said like one is active listen, another one is the validation of emotion, and then empathy, and then rapport building. Sorry, rapport building. Another one is paraphrasing. These are all the basic skills we are using in the hospitals or community wherever it is. This is very very important. So with use of these skills, we can handle the patients very well and then treating very well. So these are all the basic. I said no last quiz like that. So here match the following I have given. So based on the word, you can choose here which one is this one. Tell me a little bit about yourself. If this is coming under empathy or validation of emotion or active listening or rapport building. This is a rapport building. See, actually, so if whatever they are saying, if we are open up. Here we are using like this is open-ended questions. Through open-ended question, we have to ask like this. Then only they will initiate. Or else if you are closed-ended questions, you are using means here, the patient cannot open. They will say one word only. So like example, whether you are thinking your parents is good or bad. This is one of the close-end question. They are not open. But like that, if you are being open-ended question, they will explain more. Then rapport will build. Like here, second one is I can understand how you would feel that way. That must be really hard. I can see how you are making the effort. This is like empathy. Like they are saying like they are understanding how they are feeling, which way they are feeling. Like that only they are understand their word they are using. That is called as empathy. Third one is I understand that you are distressed by your boss words. I get where you are coming from. So like that they are using. They are here. They are mentioning like distress word. Distress word means they are feeling like they are taking their feelings, what they are feeling. Okay, that is a validation of emotion. Here they are using I see, I can understand. Please continue. Say more about extra like that. These are all the things is active listening. Then if you are using these words, no, they will think nurse, they are listening, they are actively doing whatever we are saying like that. They will think. Next one is match the following. Another one is this is this one. So patient, as I saying is, I am very angry with my husband. I just want to kill him. Nurse telling it is sound like you are irritated and frustrated with your husband. So this is called as paraphrasing. Here, whatever they are saying, patient, the nurse, they are not changing the meaning, but they are using their own words. That is a paraphrasing. Right? You are sad because you lost your friend. This is reflection. Yes, thank you. Thank you so much. One response I got. So here another third one is, so to sum up, you have mentioned several issues concerning. This is summarizing. Excellent. So this is where we have to use our skills. So we have to understand the patient situations. So last one is the initiation. What the government of India initiated for this. This is not only for this is not for tuberculosis, but who have the comorbidities like anxiety, depression. They have loneliness, sadness. They have distress level also, disorder also. Due to that chronic disease, they have so many issues. So because of this, the government of India initiated this Telemanas program. This Telemanas is under the National Tele Mental Health Program. We know about National Mental Health Program. It was started in 1982, and this one is National Tele Mental Health Program. So this is initiated the government of India 2022 October 10. So the important is it is a 24/7 available service. Number is 14416. I am repeating here 14416. So whenever you want to here, two way of things they are helping. One is distress level, another one is disorder level. Who have a distress like anxiety, this small problems due to this, someone have a first time they are diagnosing with the tuberculosis. Because of the stigma, somebody they will have some issues like the suicidal ideation, or loneliness like that they have means we can, as a nurse, we can refer them, use them. See, someone is there for listening you. If you want anything, you want to talk anything, you can talk, use this number 14416. It is available in more than 20 languages across our country. It is available. So I am working here only. So as a nurse, as a researcher, as a informatics, so many role I have, national trainer like that. So our role is we are creating so many IEC things for our telemanus cell. It is there in all over across our country, everywhere. Still start from Ladakh, end from our Kanyakumari. Here is Gujarat, from here northeast, Manipur, like that. Everywhere it is there. So if you have seen any person like distress and mental health issues, you can help with this number. So as a telemanus, yeah, here I am showing the scanner. You can scan it. All the media handle we have, all the Telegram, everything we have. So X, and then Instagram and LinkedIn, so many social media handles we are using. So if you want, you can help refer the person who need help. Thank you, thank you, thank you for organizer. Thank you all.
Thank you, sir, for your session. We will now move on to our fifth speaker for this evening, Mrs. Mercy J, Clinical Manager, South, Vantiv Healthcare, Private Limited, India. The topic that ma'am will be speaking about is TB beyond N95s. With over 15 years of extensive experience in the field, ma'am has driven continuous improvement efforts through the integration of evidence-based practices, streamlining workflows, and elevating care standards. Ma'am has completed her Master's in Science of Nursing from Dr. MGR University of Health Sciences, Tamil Nadu, and her Master's in Business Administration, Tamil Nadu. Ma'am has also been invited on various state and national level forums as a speaker on infection prevention, control, and patient safety and infusion nursing. We welcome you, ma'am. Over to you.
Thank you, Tanya. And good evening to everyone. I would like to thank Nurseslab for giving this opportunity to share with you all about infection prevention control practices on TB beyond N95. So here, because of the running short of time, just I want to crisp and informations that which I'm sharing, but expecting some of the that slide we will be focusing on the discussion sessions. So here that I would like to start like the global burden of TB, and it is about 10.7 million people fall in ill of TB in 2024 statistical data. And 1.23 million deaths occurred, including the people who are all having with TB with HIV. Around 150,000 people also was included in the deaths. And then the TB is actually one of the leading cause for the worldwide death as an infectious agent. Due to infectious agent, the death means that the TB is also one of the important cause. So, and that another one sad thing is that now many of you know that the multi-drug resistant tuberculosis is going crisis. In a 2024 statistical data, and it is around 40% of patient who are no access to treatment because of the multi-drug resistant TB. So actually that's why the infection prevention protocol and whatever that other four speakers and the next speaker who are all now going to talk about TB and then the aspects which we are in a prevention aspect and the treating the existing TB patient, which is very, very important because that the TB and also especially the multi-drug resistant TB treating and then it will be very, very big challenges because as you know that multi-drug resistant tuberculosis means the important main medications like rifampicin isocyanide is a important the medication itself that getting resistant to the patient. So we need to be more focused on the prevention aspect and then where prevention aspect, especially on MDR-TB. And just here in this picture, there is a N95 mask. So in that another, you can able to see the person is coughing and then we are just moving the aside, the person is moving aside. And if we are giving N95 mask to the particular person, can we able to avoid TB? Yes, just only for the aspects of masking, but not that N95 mask is a necessary, but it is not a only sufficient prevention measure for a TB, because that the TB is an airborne infection, which every one of us know. So that only N95 mask is not a preventive strategy. There are some other strategies like isolation, ventilation, or some more that other infection prevention protocols also we need to follow to prevent the tuberculosis in aspects. So especially here, I just want to share a basic infection control protocol, 5 pillars. So the 5 pillars are the hand hygiene, decontamination of equipment, decontamination of environment, isolation precaution, preventive use of antibiotics. And here you can see that because hand hygiene is a very important, because wherever whatever work we are doing, we are handling the equipment, we are assessing the patient, the touching everywhere will be there. So our hands are the primary culprit of infection spreading. So that's why the hand hygiene is the first pillar. And the second one is that equipment, the decontamination of equipment, which is important based on the Spalding classification, and the environment cleaning, which is important because the placement of the patient, and then the environmental hygiene, because wherever the patient is there, the entire environmental air will get infection. Whatever the surface, that microorganism will be settled. So the environmental clinical, which is important. Isolation of patient, because all the type of infection is not having a same kind of isolation precaution. Based on the transmission, isolation precaution also will be different. So the isolation precaution procedures we need to follow. The last one is prudent use of antibiotics, because the antimicrobial agent, whatever we are using, it should be prudent as per the policy, as per the recommendation and regiment, because otherwise, if the patient is skipping any doses or skipping a course or irregular medication, that will lead to multi-drug resistant tuberculosis. So all these 5 pillars, just I want to give a key informations here. So here I would like to ask the question is, hand hygiene is the first pillar. And for the preventing tuberculosis to one to another through the hand hygiene means, do we need to follow hand washing or hand rub? Only one thing we need to know: when we need to use hand rub, when we need to use hand washing. If you're seeing physical contamination in your hand, whatever, even a water also physically we can able to see, even a sweat, whatever, visibly any contamination, if you are able to see in your hand, you need to go for hand washing procedure, which is 40 to 60 seconds with the proper antimicrobial soap solution. We need to go with the hand washing. If there is no visible contamination with your hands, we can go with the hand rub. Alcohol-based hand rub, we can use it. The thing is, we need to follow, it is a 20 to 30 seconds. We need to rub your hand, need to follow all 6 steps as per WHO. That we need to remember. Because after we are applying, just flying in the air and just blowing into the your hands, then again it is no use of hand rub usage. So always follow the proper steps. So when you are following the step itself, that hand rub will get dry. That we need to follow it same. So the next one, I want to share it with you regarding the decontamination of equipments. In the decontamination of equipments, we are following as per the CDC guidelines, we are following Spalding classifications. Spalding classification means in hospitals, we are using n number of different types of equipments. So that equipments and all, we are dividing into 3 type of classification. One is non-critical, semi-critical, critical. The non-critical means the devices which is contacting with only skin, either our skin or patient skin. Example, we can say the stethoscope, or nowadays I can say that normal thermometer also we are using only the auxiliary. That is also will be like non-critical items, and whatever probes and then monitors, even a cot, tables, and all those things which is contacting with only a skin. This is non-critical. The non-critical equipments, we need to clean it with either low-level disinfectant or intermediate-level disinfectant. Here, I just want to give the example of the disinfectant. For example, the patient immediately, for one patient to another patient, if we are going immediately, we can use it as alcohol swab. But especially that this kind of equipments for especially for tuberculosis patient inside the hospital, we used to keep in isolation. So the sharing of equipment we need to avoid here. So dedicated equipment we need to provide, and especially like a BP apparatus and then stethoscope, this kind of equipments, even a pulse oximetry, all those equipments we need to give specifically to the particular patient. We should not use the equipments to the other patient, because nowadays during the rush and then your workload and all those things, if you are one time, if you forget to clean in between the patient, we unknowingly we may spread the infection to one patient to another patient, and then we know that how critically that the tuberculosis is will end up with the outcome. It will be crucial. So always we need to give a specifically, especially we need to dedicated the equipments, we need to give it to the patient. Even though for the same patient, for repeated usage, we need to clean it with the alcohol swab for immediate next usage. If it is a regular cleaning for every day morning or every day afternoon, that regular cleaning, we can go with quaternary ammonium component based solution like bacillocid, bacillol 25, this kind of solution you might be seen in your regular using of cleaning disinfection. So this and all the two main disinfections which we are using in our hospitals, we can do the same. So in a community, for example, in a home, at home, if the tuberculosis patient which we are having at a home, how we can clean it? Same, what we can clean it, the alcohol, the swab we can clean it, or the Dettol. Dettol we can use it for the everyday cleaning of the equipment which we are using at home to take care of any of the tuberculosis patient. So we can give the awareness to the community people. And then the semi-critical items, and then critical items, this will be used only in our hospitals. Semi-critical items, especially the equipments which is contacting with a mucous membrane. Example, the scopies, like the endoscopies or bronchoscopies, the kind of scopy materials, if you are using for the tuberculosis patient, the same kind of high level disinfectant we need to use. There are the two level cleaning will be there. The first level cleaning will be with the enzymatic cleaner to remove proper enzymes, whatever enzymes which is inside the scopies, we need to remove it with a proper procedure. And after that, they used to use a high level disinfectant, either Cidex or Cidex OPA. We can use it and then we can do the same high level disinfections. No need to go for double time, triple time disinfection. We can go with the single time disinfection. If it is a Cidex, we can go with 15 to 20 minutes. And if it is a Cidex OPA, 5 to 10 minutes, we can dip it. So it will be doing a high level disinfectants. This disinfection will be called in another name of chemical disinfectants. So that will be needed in a semi-critical. In critical items means whatever the material, whatever the devices which is touching on blood, tissue, bone, especially this is the OT devices, right? The sterile equipments. Sterile equipments always go with the sterilization, either steam sterilization or autoclave or ETO sterilization or plasma sterilization, but no need to go for two-time sterilization. Dual sterilization we used to say, right? Two-time sterilization is not necessary. One-time sterilization is enough to sterilize the equipments which are all used with the patient who is having a tuberculosis. So in a biomedical waste segregation here, before going into the patient room, okay, so we used to wear all the PPEs, right? Especially with N95 mask and then apron and then gloves, because whatever microorganism which is there inside the room, it will be in an entire air, the microorganism will be there. If we are entering without wearing any apron or cap, that all the microorganism will be settled on our surface, our body surfaces, right? So that's why we need to go with a cap and then apron and also gloves also, and especially that respiratory devices which is N95 mask, right? So before going to room itself, we need to wear it. And I want to ask the one more question here. Once we completed all the bedside work, when you are coming out, you need to remove all the PPE inside the room or outside the room. Need to remove the PPEs inside the room or outside the patient room. Can you please answer in a text in a chat box? Inside, okay. Can I get some more answers? Inside, okay. Okay. So that some of the people are feeling like that inside the room itself, we need to remove the PPEs, right? But if you're removing the mask and all the PPEs inside the room, but inside the room already the air is contaminated with the Mycobacterium tuberculosis, that will be settled in our dresses, and then we may inhale the microorganism, right? So we should not remove the PPEs inside the room. We need to remove the PPEs outside the room for tuberculosis, which is airborne infection. So in airborne infection patient, especially for TB, should not remove the PPE inside the room. You need to come outside the room and remove the PPE for our safety, because our safety is important. So infection prevention is not only for patient safety, especially for our healthcare workers' safety. So come out and then remove the PPEs. That is the exact thing we need to do. And then discard into the proper biomedical waste segregations, right? And then here, no need to explain entire biomedical waste segregation. This is the biomedical waste segregation we need to follow. And then here, only thing I need to highlight here. So for the red color, is only for plastics and rubbers. Even though there is a blade or there is a sputum or whatever the content, if it is a plastics or the rubber material like a gloves, only will be in a red. If it is any other material, blade and blade product or any gauze or anything, that should be go to the yellow. Because why I'm mentioning here means, for example, any infected patient bled with the blood container or the sputum container, we used to discard into the yellow bin, right? But the material is, if it is a plastic or rubber, we should discard into red color bin. And if it is a blood or blood body fluid, which is a cotton or dressing or any cloth and all, no, which is like I can say that if we are burning the material, it will be becoming an ash. So that kind of material and all should go with a yellow, right? So other things and all, it's remaining same. All the glass items should be in a blue, and then all the sharp materials should be in a white container. And here I just want to explain about just a point about the physical environment cleaning. So daily cleaning at the bedside in a hospitals, normal regular disinfectants like same basil acid disinfection or quaternary ammonium component based disinfection, we can go for the cleaning surfaces. But when the patient is getting discharged or end of the procedure in a OT, for example, I'll go with the OT procedure. If any OT procedure or any of the procedural room procedure, if we are conducting any procedure for the patient or surgery for the patient who is having tuberculosis, that particular entire OT should be cleaned. So especially the cleaning material should be wherever there is a exposure of the blood and body fluid present. So there we need to clean with sodium hypochlorite solution. Then we can go with the normal cleaning, because the sodium hypochlorite solution, which is effective cleaning to kill the microorganism like a tuberculosis. Similar way, terminal cleaning in a patient who is in a room got discharged. The discharged room, the patient who got discharged in the particular room, again need to clean all the surfaces and the equipments with the sodium hypochlorite first. And then we can go with the normal procedure cleaning. Because why we need to know as a nurses? Because we need to teach housekeepings or who are cleaning the particular room or OT, we need to instruct them to use the chemicals or disinfectants to clean the room. And here one more thing I can explain, that in a regular cleaning also, for example, normal cleaning in the room, who are going like our housekeeping or any of the F&B people are going for serving, we need to give them a proper PPE to the patient before entering into the room. Or if it is a F&B people, they need to drop outside itself. Otherwise, if they are going inside, we need to give a proper PPE. Right? So that is important in a physical environment cleaning. And I would like to touch upon the spill management. The same spill management we need to follow for the tuberculosis patient also. Either sputum spill or vomiting or urine or fecal blood, whatever the spill, all the spills are, it is harm it is a harmfulness. So we need to go with the same caution board, spill kit, PPE, and cover the spill. Use the sodium hypochlorite solution, right? That is important. You can go with a 1% sodium hypochlorite solution. You can wait for the 20 minutes. If you don't have a time, you can go with the 5% with the waiting time of 5 minutes, and then clean the area and the same kind of spill management. Here, I need to highlight one more thing for the sputum management. For example, the patient who is having the sputum excretion, the sputum cup, they used to spill out, right? The sputums, we should not discard as such as. So we need to disinfect that sputum or any blood or body fluid with 1% sodium hypochlorite solution. Just we need to add the 1% sodium hypochlorite solution into the sputum cup. Completely every sputum should be immersed, and then after 20 minutes we can discard it, and then they can clean it and they can use it. But before disposing the sputum or any blood or body fluid, we need to disinfect with 1% sodium hypochlorite solution. Fine. And the next one is a standard precaution. In a standard precaution, so we need to I'm highlighting that standard precaution already, the hand hygiene which I have mentioned, and personal protective equipments. We know that N95 mask is a equipment, personal protective equipment, but we need to add the cap, gown, and apron. All those things also we need to add when the patient is newly detected. After the 1 month of completion of the therapy only, that airborne spreading will be less. That time only droplet spreading will be there. So that time we can go with only mask. But till the time the patient who is in airborne, because especially you will get then how you will identify whether the patient is in airborne or droplet. You can get the information from the that particular primary doctors, or if that particular patient is consulted with a infectious disease doctor or infection control team, you can ask with your infection control nurses or the microbiology lab. They can give the right status of the patient. So based on that, you can put the isolation. So anyway, the patient who are TB, that based on the infection control nurse's instruction, you will be put the patient in a negative pressure airborne isolation room. Till the patient who is in an airborne isolation room, you need to put entire PPE. But again, I'm saying PPE should be removed outside the room, not inside the room. And the patient placement should be in isolation ward, and especially for airborne infection patient should be under negative pressure room. So that is important. The negative pressure room is important because negative pressure room means inside the room there is a negative pressure. When we are opening the door, environmental, that means corridor air pressure will be more than the room. So the infected room air will not go outside the room when we are opening a door. So we are not contaminating outside the room. So that's why we need to maintain the negative pressure isolation room. And then environment cleaning, we saw that, and then linen segregation. The linen, whatever the linen, bedsheet, and then pillow cover, whatever used for the tuberculosis patient, we should not put into with the normal patient bedsheet. So we need to go with the separate linen segregation. You can mark a separate cover as a policy of your organization, or you can mention that the infected linen kind of, because this linen should not treat with the normal linen washing. It should be treated cleaning. Pre-wash need to be done with the sodium hypochlorite solution 0.1%. They need to do the disinfection. Then only we can shift the linen to the normal the washing. So that's why that disinfection is of the linen should be important. Safe injection practices should be, because the microorganism transmission we need to be taken care, and cleaning, disinfection, we saw that. And here one more thing I want to highlight is that the fifth pillar is prudent use of antibiotic, because as in the initial conversation I have mentioned that if that prudent use of the proper use of antibiotic was not done, then the patient will be with a multi-drug resistant tuberculosis. Because the multi-drug resistant tuberculosis will be why the patient is getting multi-drug resistant tuberculosis is that a simple thing. because of disconnection of treatment or improper dosing or improper frequency of medications, and then with the hot water on in combination, improper combination of medication with any of the food or anything, that is also will affect the medications pharmacokinetics and dynamics. So they need to take a proper medication as per the protocol or prescription, or the patient is having a previous history of already they were completed the 6 months course, so repeatedly they are getting a TB, and already they were completed and again they are getting TB because of immunocompromised situation. Then again they are getting a chance to get a multi-drug resistant tuberculosis, right? So for multi-drug resistant tuberculosis, one more thing also there, the patient A who is having a multi-drug resistant tuberculosis can spread the same multi-drug resistant tuberculosis to the other patients also who is immunocompromised, or to everyone, right? So that's why the that multi-drug resistant tuberculosis is very dangerous. And then because the drugs are already resistant, so with what drug you can able to treat the particular patient, right? And it should be higher, and that sometime maybe pan-drug resistant also may come if the person is not taking a medication properly. So that time, if it is a pan-drug resistant TB, if we are getting, there is no medication to treat the particular patient who is having a TB. So to avoid the pan-drug resistant, even multi-drug resistant also, we need to reinforce the patient or oral, the person who got affected with the TB, we are the person should educate them, and then we need to educate them on the medication, treatment, and infection prevention method to avoid spreading to others, right? And just for community health measures, already our other speakers were explain about the different types of measures what we need to do. Just I'm highlighting education to them regarding the cough etiquette and adherence stigma reduction and all, and then integrated care on TB risk, because the patient who is having HIV or diabetes, malnutrition, or immunocompromised people, they are having a more prone to get a high risk of TB, right? And then the surveillance on the monitoring of resistant pattern patient who is having, because even though in ICU or what wherever you are meeting a tuberculosis patient, if you are getting to know that how many of the resistant, seriously the lot of patient are becoming a resistant nowadays. Even normal resistant, even we are also may have, but the tuberculosis resistant, the people who are all having a tuberculosis, we need to be taken care, and the preventive measure especially, because taken care which we are doing, but we need to be safer also. So prevention of infection control and even infection prevention and control measures, not only for the patient care, and it is for our care also for protecting, because for our production is our family production. Our family production is entire the area, and then the community entire production. So as a nurses, we are having the responsibility to protect the entire community, and then education system we can share our knowledge too. And the key consideration here, I just want to mention on the N95 mask key consideration. As per CDC guidelines, the N95 respirator, we need to wear the N95 respirator as a healthcare workers where the patient who got confirmed with the tuberculosis, like tuberculosis confirmed patient wherever they are having, or airborne, wherever airborne isolation patient or confirmed patient. And then one more thing, there is a we cannot give the compromisation or the convenience factor, like, okay, if you're wearing N95 mask, 100% can able to tuberculosis transmission can 100% can prevent. No, even though as per experimental, 39% of healthcare workers experienced facial ceiling leakage in one of the studies. For example, you were weird, even in a corona time also, we were worn all the N95 mask, right? You can able to remember that how many of you had the ceiling problem. Did everybody know whenever wearing the N95 mask, did you got a complete ceiling in your face? No, right? You might not be getting a complete ceiling, everyone. Maybe some of us may be received, or many of us who are all very slim people, or because the standard size the company people are preparing, but everybody's face the ceiling will not be. But Actually, as per a CDC or WHO recommendation, every year they need to do an annual fit testing of the respirator. Based on the respirator testing, the sizes should be available for N95 mask, right? So that should be there. So that Indian side, it should be no, if it is coming in at least upcoming days, it will be helpful. And but it is a recommendation. And for example, some of the areas which is a high protection, high risk scenario, which there is a need, there the WHO and other guidelines and all suggesting the powered air purifying respirator should be used. So, okay, thank you so much. Now, I would like to again express my thanks to each and everyone for listening. And then I would like to thank you, Nurseslab, for giving this opportunity. Thank you so much.
Thank you, ma'am, for that detailed and very informative session. So I will now introduce the sixth and final speaker of this evening, Mrs. Rekha Biju Varghese, Nursing Supervisor and Clinical Auditor in Dubai, UAE. Mrs. Rekha brings over 25 years of progressive experience in nursing, clinical leadership, and healthcare quality. She holds a Master of Science in Med-Surg Nursing from Dr. MGR Medical University, Tamil Nadu, and a doctorate in Management Studies. Ma'am has a strong academic and professional portfolio, having presented papers during her postgraduate studies, conducted workshops, and participated in international conferences. She is a recognized speaker in educational programs under Dubai Health Authority and an active member of its Nursing Executive Committee. The topic that ma'am will be presenting on is TB contact tracing, a nurse-led public health strategy. We welcome you, ma'am. Over to you.
Thank you so much for giving me this opportunity. I know everybody is saturated so after having this 5 sessions. So I'll just briefly introduce this topic. So before going on to this particular topic, that is TB contact tracing, probably during the COVID times, you are familiar with this contact tracing term. So this is a picture which shows, I just want to share 3 scenarios. So one is, if this is a picture where a few years ago, a mother brought her 4-year-old son to the hospital with fever, loss of appetite, and persistent cough. She told the nurse, "I don't understand why he is not improving." The nurse gently probed and learned that the child's uncle, who lived in the same house, had been coughing for months but never got checked. By the time the little boy was tested, unfortunately, he was already having advanced TB. Very miserable. One small piece of missing information, one missed opportunity for contact tracing, changed the course of that family's life. When the nurse looked back, she said something that stayed with me. If I had asked one more question, I could have saved him earlier. So this is why we are here today. This is why nurses matter in TB contact tracing. Because one question, one conversation, one moment of awareness can save life. So the power of one question in TB tracing. So the next scenario, the nurse was caring for a woman with suspected TB. The nurse was scared, withdrawn. The patient was scared, withdrawn, and avoided answering questions about her family. Then the nurse sat beside her, held her hand, and said, "You are not alone. Whatever you tell me, stay safe. I am here to help you." Slowly, the woman shared that she lived in a small room with her sister and 3 children, all coughing, all afraid of being judged. As the previous speakers mentioned, it's all about the stigma. People might not say what is inside the family. The nurse informed the TB team immediately. All the children were screened and one tested positive early enough to be treated without complications. Good. So one trusting conversation, one safe space created by a nurse, one full family is protected. How important it is. So the third scenario, a senior nurse once shared with me that early in her career, she treated a man with fever and weight loss. Only that. She focused on stabilizing him clinically, but never explored his living conditions or whether his family had symptoms. 2 months later, his wife was admitted with severe TB. The nurse said she always remembered that moment, that not as a failure, but as a turning point. So she said to me, that day I understood that nursing is not just treating the patient in the bed. It is protecting every person connected to him. From that day onwards, she never missed a chance to ask about the household contacts, especially in such scenarios of fever, persistent cough, and loss of weight. Sometimes it takes a painful moment to ignite the purpose. But that purpose is exactly what drives TB contact tracing today. So coming to our discussion for today, so this is, you must be already knowing what it is all about, contact tracing. Is it so? Yes. Contact tracing? Probably everybody know by now what is contact tracing, right? So it is about systematic way of identifying, evaluating, and follow up the individuals who have been exposed to an infectious TB case. So with the purpose of detect latent or active TB early and prevent further spread and protect high risk group, especially children, immunocompromised and elderly. It is a most effective public health strategy to break the chain of transmission in any communicable disease, especially when we are talking about airborne, that is TB. That is the best example which we can give for a airborne infection. So nurses are the front line, often the first point of contact in TB control. How can we contribute to it? So by conducting interviews where we take the history, where we do examination, where we talk to the patient. So by then you will understand, you will not miss anything which can give a significant answer to a specific diagnosis. Performing screening tests, educating patient and families, and ensuring adherence to treatment as the previous speakers have mentioned. And coordinating with public health teams also very important, that we can control TB in many means. And providing psychosocial support is a very important aspect where people will be afraid. They'll be thinking of the stigma, the social stigma. So where there comes the importance of a nurse giving a psychosocial support. So tracing, how does it? So why contact tracing fails? As you all know, nurse as a leader, she fixes it. How can we do that? Highlight the real challenges. So underreporting. So many of the times, as I mentioned in the scenarios, what happened? People did not collect the history, or neither the nurse or the physician, and they did not think about what is happening in the family. So that is the main important thing where underreporting. So most of the people from the low income group, probably, they think what others will feel. So underreporting. And the next one is stigma causes hiding of close contact. Even I am infected and I don't want my family members will be under the stigma. And migrant mobility. So mobility happens nowadays. The migration happens very often. And as the previous speaker mentioned, that causes even in the developed countries. So not only in the developing countries. And delayed follow-ups. We keep testing. We keep with ourselves. Then we go for a checkup. So probably the history is not given properly. And what happens? We'll start with another, just an antibiotic of first line, and still the persistent cough, the weight loss. Later it comes up. So delayed follow-ups. Weak coordination between the facilities. Once it is identified, it's the responsibility of the facility to inform the infection control team and to be taken care. So this is also and limited risk prioritization. So how the risk is identified through awareness and by categorization of each case, we can have the risk prioritization and gaps in documentation and data quality. So we tend to forget collect history, but collected history, again, documentation fails. So what is a public health backbone of TB control? Again, the critical role of surveillance, trying to find out where this occurred, the indexing of the case, how the TB contact tracing integrates in the national TB program. So we have had a patient or we have treated them, and what is about the connections they have. So this is all about the contact tracing and data-driven decision making. So the contact registers, dashboards, KPIs in order to make sure that we don't fail in reporting the cases. So why do we say the nurses are important? As I mentioned earlier, the history taking is very, very important, and notifying the person who is supposed to. So the communicable disease section or the infection control nurse need to be informed as early as possible in order to find out what is all about the patient and the community or the people around them. So epidemiological interviewing, as I mentioned, as an investigative style. In the second scenario we mentioned, we missed that she was having a few people coughing, persistent coughing, and inside the family. We tend to forget. Husband was treated for something, but we tend to forget who was with him. So this is an investigative style of getting a risk stratification of so how the children are there or immunocompromised persons are there. That needs to be understood. Then field outreach. So not only inside where we are treating, also the home visit. Work site visits are also important. Behavioral counseling to improve the adherence. So very important, as previously mentioned in the previous session. So we need to educate people how important to adhere to the treatment. That is also very, very important to avoid MDR. Okay. Case management using public health framework. We have frameworks. How effective we are using it as a question remaining. And quality auditing of TB contact tracing. Very important to have the tracing of the contact and screening them properly. Okay, so using safety and quality tools like failure mode effect analysis, root cause analysis, tracer methodology, these are to be conducted in order to make sure that we are following the person who is found positive. So in order to ensure that we cover the area, in order to avoid the spread of the disease. Okay. So in this, let me introduce one concept, that is 5-3-1 model. So what is 5? 5 steps for initial tracing. So identifying the index case. Index case is a new case we identified. Conduct the interview. Map the exposure, where all you have been exposed to, your wife, your family, your workplace, everything. Map the exposure network. Prioritize the high-risk contacts. As I mentioned, high-risk contacts are children, then immunocompromised people, elderly. All these people will be the exposed network we need to be mapped. And prioritize the high-risk contacts whom he had contact with, and plan how we can outreach them, get them screened, and to be identified. Okay. Second one is a 3-level screening. The high risk, as I mentioned, medium risk, and low risk. And the third one, only one goal: break the transmission within 72 hours. As early as possible, we need to break the chain of transmission. So coming to that, every nurse helps in identifying the index. How do we do that? Do you believe in that concept? Yes, a TB contact trace cannot begin unless someone identifies the index case. So 80% of the situation, this happens in hospitals or clinics. Even community health nurses have a very big role in this. So we nurses contribute by noticing the symptoms: cough more than 2 weeks, fever, weight loss, night sweats. All these things has to be our intelligence, the logical thinking will definitely matters a lot. Escalating the concerns early, ensuring sputum collection is done correctly, triggering the isolation precautions and educating them, and informing physicians and the infection control team, as I mentioned earlier. This is our responsibility where you can break the chain. We may not conduct field investigations, but we can initiate the entire tracing chain. This is what the contact tracing all about. So nurses reducing stigma, the biggest barrier of. So we tend to save our family, saying that I have, or the family or the neighbors or whoever. Why? Because we don't want, because of me, anybody is infected. But that can be broken by a nurse, by her intelligent way of dealing with the patient. Patients disclose contacts only when they feel safe, and so show the respect, have the trust, and get the history done. So we nurses influenced by how TB is explained, then how fear, shame, and misinformation are reduced. We can influence how family are encouraged to get screened, and a single supportive conversation by a nurse can open a door to an entire family and to the entire community to come forward for screening. This is very important. So accurate documentation by general nurses, all of us, in every nurse can protect the community. Missing and incomplete hospital records can cause tracing failures. Nurses ensure correct recording of address and phone numbers to trace them, and to clear notes and patient movement in the hospital and even the community. Exposure list if staff and patients were in contact. Proper handover to the infection control team. Good documentation by all of us, whether you are a specialized nurse or a general nurse. So it prevents the contacts from falling through the cracks. So what happens, the TB contact tracing in India? TB contact tracing, we have a national TB elimination program begins when a TB case or the index case is identified in the hospital or clinic, where the household and close contacts are screened early. High-risk groups, children, elderly, and people with comorbidities are prioritized. Early detection and preventive treatment stop further spread. So therefore, nurses play a very, very important key role in identifying contacts, reducing stigma, and protecting families and communities. So this is the same slide as, okay. So TB elimination is not the responsibility of one department or specialty. It is a nursing responsibility across all settings, whether you work in the ward, ICU, community, OPD, or any management, even in the administration or in the management team. Your actions determine how early TB is detected and how quickly transmission is stopped. So yes, we can end the TB, and nurses will lead the way. And I appreciate Nursing Lab team for taking this important topic into consideration and giving all of us, we take the responsibility that we can end TB as nurses. Thank you so much for everybody.
Thank you, ma'am, for that detailed and very excellent session. And thank you to all the participants for bearing with us, even though we have extended the time limit. Thank you all for joining.